because we are currently doing knee arthroscopies, I'll take you quickly through one of the newest technologies that we've acquired in ACL reconstruction. So previously, and what we've been doing for ACL reconstructions, we've been using the baton on the femur, and we've been using screws on the tibial side. But because of high demand and most of the surgeons requesting us to be able to see if we can be able to get the all inside ACL reconstruction technique. So Smith and Nephew has come up with a device called the True Nerve, which is used for making the tunnels both on the tibial side and on the femur side, so that you can be able to have your graft fixed in the tibia from inside the joint, and the femur also from inside the joint. Initially, we used to pass the graft from outside the tibia, through tibia, and then you get it through to femoral side. By the moment we are working on technique whereby we just have to do everything all inside. So that's the basis of my talk this morning. True Nerve retrograde drilling system. If you look at whatever has been projected on the screen, you'll see three basic instruments. The first one on the left side, it's a cannulated drill. That drill, it's 4.5 millimeters, and it's 2-in-1. It also has from 5.5 to 11 millimeters. So you can be able, you do everything using one device. The second pin is the guide pin. Then the third one, it's a lasso. It's used for passing the graft. So why would a surgeon choose a retrograde rimming system other than choosing the traditional antegrade system? Number one, it allows you to visualize the ACL footprint from the medial portal. Number two, there is no need for hyperflexion of the knee beyond 90 degrees. For example, if you are doing the traditional antegrade, you will find that we usually insist for someone to hyperflex the knee so that you can be able to pass the pin, and also you can be able to drill. So when you're using the all inside technique, you don't have to hyperflex it beyond 90 degrees because everything is visible. Number three, it lowers the chances of damaging the medial femoral condyle. Number four is its value in ACL revision scenarios. And also avoiding physics in pediatric ACL reconstruction. That's in different angulation. Then the last one, it offers greater flexibility in tunnel trajectory, not bound by the medial portal. Allows for all inside ACL reconstruction. So this is the instrument. Basically, this is the new device. So if you look at it, you'll be able to see various parts that have been labeled. But when after you're done, you're passing through the booth, I have various that I'll be able to show you in practical what exactly I'm talking about. So when you're doing an ACL reconstruction, you must have the guide. Then after having the guide, you pass the pin, the one that it's here. Let me show you. Now that's the guide. When you're having that guide, you have to pass the pin from here. I don't have something to direct it better, but sorry, I have the pin that is in the middle here. Then you have the guide. So the traditional method of ACL reconstruction that we've been using, where you've been drilling from inside. So you pass the pin from here, then from there you over-rim using the true nerve. So I say that this one is 4.5 millimeters. So after passing the pin, you over-rim using the 4.5 millimeter drill. This 4.5 millimeter drill, you'll be able to deploy the blade depending on the size of the graft that you are having. If it's 8 millimeter or 7 millimeter graft, you'll have to, for example, you can see here it's labeled 9 millimeters. So you'll choose the one that is matching the size of the graft, which is around 7 or 8 or 10, depending on the size of the graft. So the blade that's going to be deployed, it's the exact size of the graft that you are having. So you deploy it. Then after deploying it, you will be able to rim in retrograde. So from go back to the other slide, then you'll be able to rim from retrograde. Yeah. Acufix true nerve overview developing. So first and only, it's a first and only cannulated drill designed for guided retrograde rimming over a guide wire. Allows for precise tunnel planning and placement with the 2.4 millimeter guide wire. It produces concentric tunnels as true nerve follows the guide wire back. This is the guided system. You have the guide, then you have the pin that you drill. Then after that, you are able to rim with a 4.5 or 4.9 millimeter drill, but you must protect using a curette so that the pin doesn't injure other parts of the knee. Then you over rim using the true nerve. This is the blade. Depending on the size of the graft, you have from 5.5 millimeter to 12 millimeters. But currently, because we have the screws that are 10 millimeters, it's 5.5 to 10 millimeters in our Kenyan setup. Thank you so much. If when you're done when you are taking tea, you can pass by our booth. I'll show you in practical scenarios. Thank you, and I appreciate so much.
Thank you, Wycliffe. You'll do the talk now, yeah? Okay. So while we are still waiting for the flipboard, I think we'll ask Dr. Prof. Opondo to give his talk on graft options and tunnel placement in ACL reconstruction. Flipboard is here. Flipboard is here.
So we start with the case, I think. Yeah. Yes, yes. Good morning. Is this working? Yeah. Good morning. So this morning we have had a small change in the program. One is that we are going to have a clinical case discussion, which is like an overview of the case that we had yesterday. And I'll just give a brief history, then Professor Mustafa will take over. So we had a 35-year-old male who had an injury while playing football on the 1st of March. And he had a non-contact twisting injury to the left knee, and he initially was managed severally before he came to see Dr. Winger. So yesterday, and of course he has had x-rays and MRIs and everything, and in summary therefore the pre-op investigations revealed that he had a complete ACL tear, and he had a tear of the left and of the medial and the lateral meniscus. On the lateral meniscus, he had a radial tear, and on the medial meniscus, he had what was like a small horizontal tear. So last evening, we went to theater arthroscopically. We, of course, confirmed the ACL tear, and we repaired both meniscus. So Prof will discuss basically the surgical techniques and everything. And that will also help us, because that will make us shorten the other talk like that I was going to give, because he also demonstrated how he does his grafts for the quadriceps tendon. Welcome, Professor. Semitendinosus, not quadriceps. Karibu. Thanks.
Can you make this one? Okay, then I will give you this on PowerPoint. Yes. Drop this. I will stand. Good morning, everybody. So the case yesterday, it was a full case, and who asked me about the weight loss, weight gaining effect on the knee. So this was a typical case. There is a slight injury on the football field. It's not a major one. But because this patient was bulky, he had ACL, total rupture. He had MCL, grade 2, definitely. There was hematoma, and the serum of the hematoma when I entered the medial side, and there was lateral meniscus, radial tear, and there was medial meniscus, posterior tear, almost total, more on the below. And then there was a cartilage depression on the lateral femoral condyle, typically that we see in these cases, and plus irrelevant, but he had patellofemoral chondral lesion, grade 2, not 3 or 4. So we didn't do anything about this. And there's definite indication to treat this patient, reconstruction for sure. And because of his age, it has to be reconstructed. So what we did was the sequence of how to approach this patient is first to evaluate and put these on the head. What are the pathologies? And then before surgery, we sequence what we are going to do. First is examination under anesthesia. You confirm your diagnosis that you have an ACL rupture, because if you are not sure, you have to go to diagnostic first and then the graft harvest. But if you do the graft harvest first, you save time. And in this case, we passed over the tourniquet time because we wanted to do it in one shot. So examination under anesthesia confirms the diagnosis. It's ACL for sure. And then graft harvest. The graft choice in this patient, if it's elastic patient, stiff choices should be preferred, like the patellar tendon or the quadriceps tendon. But in a normal elasticity joint, and this is not a high professional athlete, I would prefer semitendinosus, hamstrings, because of the easiness, both for the patient and both for the surgical terms. So we take the graft, and the back table prepares the graft, and then prepare the femoral tunnel just to measure the depth. So we have the loop size, 20 millimeter, 30 millimeter, because the back table has to know the size in order to prepare the graft, because he will prepare the graft and loop it around the CL, endobutton CL. And then depending on the difficulty of the meniscus tears, approach them. If they are simple, I would think that the medial peripheral tear is simple, because all you do is you shoot in the implant and there's not much. But the radial tear of the lateral meniscus, it's displaced, difficult to heal. You have to precisely do it. So I prioritize it. I want to make sure that it's under control. So what we did was work on the lateral meniscus. I will draw how I did it. And so put in outside-in sutures. Leave the sutures PDS, number one. Leave them outside. Don't tie them, don't finalize them, but finish them, because you have to make sure that you are in control of the situation. So we worked on the lateral meniscus, and then we prepared the tibial tunnel. We prepared the tibial tunnel fully, and then back to femoral tunnel, sizing it. Tibial tunnel was 8 millimeters, and the femoral tunnel was 7.5 millimeters. So we concluded it, finished it, passed the graft passage, and fix it with bioabsorbable interference screw. It was 8 millimeters, but we put in 9 millimeter bioabsorbable screw in 30 degrees of flexion. And then we did the medial meniscus all inside, and then lateral meniscus suturing. So it's a full case. And if you ask me, which one of this is the most important, any of them will cause a failure or a reoperation. But I would prioritize mechanically the femoral tunnel location at the #1 priority, because the rest are you have to it may be caused by accident, but femoral tunnel mistake is done by believing in that this is the correct place, because there's so much information in the literature and there's so much scenario and talking going on. So it's usually a matter of not knowing enough. It's a matter of knowledge. The others may be a matter of skill, tiredness, and not giving enough importance. But so I would put femoral tunnel location the first. So I will one by one go. How about I tear this? And then I put this in the ground. So I remember the graft. This guy was huge, but his hamstrings were very bad in terms of diameter. Only 8 and 7.5. So by literature, we should not put less than 8 millimeters. It's prone to failure. But we did 6 bundles in this patient. So how to do 6 bundles? I opened the oblique graft, and sartorial fascia is there. Above the sartorial fascia and the gracilis, I made an oblique incision. So you reach over the sartorial fascia, and you see the MCL. That's where I saw the serum of the hematoma and the lagging of the MCL. It was not so evident in the MRI. And the graft. So the graft comes out like this. One was 32 centimeters long. The other was 27 centimeters long. So you take, in order to prepare the 3 bundle in each of them, so normally what you do is you put sutures on both ends, and then you just pass it around the loop. So 2 strands, this is the loop of the endo button. So you have, this is what is done normally, classically. So, but in order to do a 3 bundle, what you do is you prepare the Krakow suturing on each end. And this is the endo button. We measured it to be 20 millimeters. The endo button CL, that's what we did in the early time. And then this is the 32 centimeter one. So with the Krakow on this side, we make a secure knot. And then we pass this part over here and then back here. So this one has the suturing entering, and then we make another Krakow like this. So we have 1, 2, 3 strands. And we did this both for the gracilis and the semitendinosus. And then we have a 6-strand graft. Please look at the literature or write me. I will send you the technical details. It's very easy to do. And you have a, if you want to do double, quadruple like this, I did a 6 bundle, a quadruple like this, you will have a, this was 32, 20, you will have 16 centimeters long. We only need 8, 9, maximum 10 centimeters long graft. We don't need more than that. 9 is very good, so it stays within the tunnel. We don't want it to be outside the tunnel. It has to be inside the tunnel. 2 centimeters up, 3.5 in the middle, 5.5. And 3 in the tibial tunnel, 8.5. Big guy, 9, 9.5, 10. So you have to get the diameter larger. It is shown. It is better stability in these cases. So we prepare this and we put it in vancomycin soaked sponges. Anybody here use vancomycin? Since I use vancomycin, I have 0 infection, ACL infection. So I highly recommend vancomycin. Simple, 1 flacon, and the problem is solved. The femoral tunnel location. This is the side ways, and this is the Blumenstadt's line like this, coming. So there's always a discussion where to put it and everything. And there's the double bundle, posterolateral AM location, etc. And so I follow the anatomy. How I do it, I follow the anatomy. So I use the arthrocare just to gently, like trimming your hair. Just I trim, 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 trim. I follow the anatomy. I see where the ACL remnants are. And we are looking from here in this direction. This is what we see. It's difficult to see the back part. We are looking from here. So the notch is, you should divide it into 3 parts, the notch. It's definitely in the lower third part and deep into the joint. And it's not easy. The synovia of the PCL covers it. Remnants of the ACL covers it. So you have to trim it down. And then you will see that it is a location like this. And then there's the intercondylar, I forgot the name, but between the PL so-called AM bundles, there's a ridge. So you will notice mostly 2 ridges. One is definitely up here. You will see the slope coming down like this, and then another one here. So I want to make sure that from the posterior part to the anterior part, that I put it in the middle. So there's a ruler to measure it. There's a ruler to measure this distance. And it's in the Smith & Nephew package, and it's a ruler like this. And it's about 5 centimeters long, and you bend it. Freddy Fu, we should remember him. This is his personalized ACL set. So you insert it in like this, and then you put it in the middle. So I don't use an aimer, offset. I look at the anatomy, and if my hand goes array, I allow it to go posteriorly. I would accept 1-2 millimeter of posterior location, but not anterior location. So the lateral meniscus. So I'll come back here for the tibia. The lateral meniscus was bad. You know, I talked to Samuel and I said, you have to talk to the patient that there's a there may be a problem in healing in this patient, because popliteal tendon here, it's ruptured here, and this part displaced. So this part is mobile. What we did was we inserted needle from the outside, and one had a loop in it, and the other had a just #1 PDS. and we pass this is the loop, this is the PDS coming in, we passed it through the loop. And then with the pulling of the loop, this part came and it was pulled by the loop. So once you pull the loop, so the number one PDS goes inside and out again, and then you tie it on the outside. This is what I did finally at the end. Lateral skin incision, longer than the graft incision, lateral skin incision and fascia lata incision longitudinally, expose the capsule and tie it over the capsule. Because it was elongated, I checked if it would be tied over the fascia lata, but it didn't work. So it took us another 10-15 minutes to open up the fascia lata, and then I tied it over the. So out of the surgery, ACL is perfect. I feel very confident. Medial meniscus is very good, but this one we leave it to goodwill. Let me say it like that. And then after but at this point in the surgery, I did not tie it. I just left the sutures outside. I did the delicate work in the beginning of the surgery to passing the needles. That was the difficult part. And coming to the tibia, the best way to confirm your entrance is actually from the lateral scopy view. That's what I found the best way to do. From the anterior to posterior, your tunnel should be at 40 to 60% junction. But to put the C-arm into the OR, to find a good radiologist to get it, it's very difficult. But this would be the ultimate, I would say, what tells you that is the best. So you have to estimate it, and then, so the closest way to get this is to open your tunnel center at the posterior part of the lateral meniscus anterior horn. So it has to be, your tunnel center has to be at the same level of the lateral meniscus posterior anterior, and this will coincide with 40 to 60. And how to do this? It's deceiving. So you look at the through the arthroscope, you see the bundles, remaining bundles coming, and you see, oh, it's in the bundle, but maybe it's coming out here in the front. It has to be 40 to 60. If you do it anteriorly, you know it will impinge in extension. So this is my tip in the tibial tunnel preparation. And then back to femoral tunnel, then it's easy. You have your 4.5 millimeter reamer opened. You put your in extreme flexion. It's important. Why is it important? If you bring the tibia to extreme flexion, then you get out around the knee. If you do it in 90 degrees, your tunnel will be going like this in a long 50, 60 millimeter. So extreme flexion is what we need. And then you pass your pin with the loop behind. You pass your You have your tunnel here. You have your tunnel here, and it's going 30 millimeters. And then another 10 millimeters. It's not like this. And then 40 to 60 here %. You first pass a suture inside through the pin, and then you bring in your graft, which stays 20 millimeters here and 20 millimeters loop connected. And then we just had 5-6 millimeters of protuberance in the outside. And then I put, it was very rough, tight, so I put it around here. And we put 9 by 30 millimeter. And then the medial meniscus, it was easy enough, in very much in 20 degrees, 10 degrees extension, almost full extension. Because the MCL was grade 2, you could open it, and then 2 fast fix made it very tight. So if it was just medial meniscus, before I go to rehabilitation, and then once I stabilized the ACL, fixed it, the 2 fast fix in the medial meniscus, then back to the lateral meniscus, and just repair it through the fascia lata. Surgery is finished. And then skin closure is easy. But about the rehabilitation. So now we have 3 elements that needs to be approached rehabilitatively. The ACL. If I did ACL only in this patient, the patient would be so happy. Because right now, 12 hours after the operation, 16 hours after the operation, I would get him up and make him walk without crutches. Only ACL if it was. And then the patients are miraculously saying, "Whoa, what happened?" But if you think of, in terms of biomechanics, the ACL construct is very strong. Laboratory studies show up to 2,000 newtons of resistance to load. And what is walking? In walking, there is no stress on ACL. The guy is not pivoting. It's like doing a magic and distorting the image of the patient. As long as he uses his muscle strongly, and you just hold him, make sure he doesn't fall. This gives a lot of appetite for the patient for further rehabilitation and further trust in you. Only ACL though. If it was. If it was ACL plus medial meniscus, I would let the patient walk with crutches. 50% weight bearing. Right now. I put my foot under his foot and try to feel the weight, how much he presses, and then tell him this is how much you're going to press. With crutches, immediately have him walk. But flexion, 4 weeks of only 40 degrees, 40 to 60 degrees. And patellar mobilization and full extension. Very important. These 3 things. Patellar mobilization, full extension, and 40-60 degrees of flexion. And if you add lateral meniscus to this patient, 4 weeks of full extension. See the difference? Only ACL and 3 of them combined. If you don't do this, if you allow weight bearing, or flexion, lateral meniscus will not heal. And then, no matter how successful you are at ACL, you failed. You have to do another surgery. You have to resect the lateral meniscus, and then you have to revise. So this is the if you press weight on it, the lips will distract. Is that post-op X-ray? Is there something you want to show me? Like we talked yesterday, it's always very difficult to get a true lateral X-ray. But the endobutton is right where it should be, and it's good. May I pass through? So, any question? Question from you? I thought so.
Thank you, Prof, for the good case, good explanation. I have two questions. And the lateral meniscus, the medial meniscus, no problem, ACL, no problem. But the lateral meniscus, especially the radial tears, most of the time it's a dicey situation, and repairs is difficult. And we know if it's a complete radial tear, the meniscus is basically functionless, so you really have to try to do something. So, if you had, I know you don't have the Novo stitch, Smith and Nephew, I don't think they've brought the Novo stitch. But if you had it, would you rather have used the Novo stitch so that you have an all-inside, you do all-inside mattress sutures with the Novo stitch? That's one question. Second one, yesterday you mentioned about the fibrin clot. Would you give us some tips and tricks of how we can make fibrin clots locally? Because we know we have to use a glass beaker, we have to use a glass rod, and most of those things are not available with us. Thanks.
It's very tricky. You should try and learn glass beads and glass rod. Glass makes blood clot better, quicker, and then as it clots, you have to shape it, and it's best to shape it over a thin suture. So you lay it around the suture, and as it's clotting, you should pass spiral sutures around it, and you should try to get a loop of it, or a segment of it in an oval shaped, and then you should have sutures on both ends. That's the best way. Otherwise, because of the pressure and the suction within the joint, the clot goes elsewhere. So you have to pass with anything, shuttle suture, you have to pass it where you want it to place. You pull it towards that place through an absorbable suture. And then you fix your meniscus, repair your meniscus over the clot. It's very difficult. But once you do it, then it becomes common practice. Any more?
Not using an all inside, rather than using inside out sutures and suturing them over the capsule. Would you rather have used all inside if you had the gadget?
For this lateral meniscus. Okay. We're talking about money now. This is #1 PDS with spinal needle, and I've used it for 20 years now. If you do it well, you get a good result. So that's why I put it first in the line. I put it here. So it's actually the first in the real surgery. You prepare the femoral tunnel is just to measure. So before I do anything else, I work on that. That's how important the radial tear of lateral meniscus is. There's a chance to heal, but you have to do it perfectly. The timing of the surgery.
How soon should you do it? Or
When one time I went to London. I'm going asking the bus driver, this stop, college stop, where's the college stop? And the guy is with an accent. He's telling me the bus will tell you. So I didn't understand what, but he said the bus will tell you, which meant that it will announce the college place. He didn't actually answer, and the knee will tell you. My answer is to you. So never hurry the knee. The knee will tell you. Full extension, 100 degrees of flexion, neuromuscular control. That he's able to walk without the pattern-wise, without a pattern loss. He may walk slow, a little limp, but you should normal gait. These are the three parameters. If you push it, then you have a disaster. Extension loss and everything.
In terms of rehab, would you alter the, for example, your rehab based on which part of the meniscus, like if you repair the posterior versus anterior, and now considering, for example, if it's lateral, you want a full extension for 4 weeks. Would you do the same if it's an anterior horn, for example? Or do you adjust based on that?
It's definitely adjustable on the patient. I put this patient in full extension, not because it is best attached at full extension, but because 4 weeks is a long time to immobilize. So if this patient is going to have a contractor, I'd rather have it in full extension rather than 30 degrees of flexion. That's my aim. So I make sure once it's in extension, if the lips are touching each other, then I'm happy, full extension. That's why in the last 15 minutes I asked them to extension, flexion, extension, flexion. This is the reason. To make sure that as you were bringing into extension, I was pulling on the ropes before I finally suture them to see if they overlap and come to each other. That was my reason. And so two things you have to be careful of in the rehabilitation of the meniscus tear. We are talking about weight bearing and range of motion, and then muscle control, etc. Proprioception. These are the basic elements of post-op rehabilitation. So think, what would happen weight-bearing wise in a vertical tear? If you allow the patient to bear weight, the vertical tear will force the sutures. So you don't allow weight bearing until there's some healing. And think about the flexion. Now before that, weight bearing, think about the posterior medial meniscus. When you bear weight, what happens to the posterior meniscus? They compress each other. So weight bearing is actually good for peripheral tears. And now think of range of motion of the posterior meniscus. If you flex the knee, they detach. So in a vertical tear, you don't allow weight bearing and you don't allow flexion because they detach. But in a posterior peripheral tear, you allow weight bearing because it's good. it will compress, but not flexion, until 4 weeks. Once there is some healing, that takes over the repair. Any more questions? Thank you. So, could you do the PowerPoint? Yes, you have. Can you give me the white? Flash drive. Can you give me a flash drive on a little disk, any disk? Yeah, I will give this. Once I know. It's in my bag.
Sasa uko sawa? Sawa. Mimi ndizo nje tu. Sawa basi.
So now I will talk about patellofemoral
Question, Professor. What is your take on bracing after ACL reconstruction and after meniscus repair?
I not use brace in simple ACL. I don't use, but in this patient, I would use bracing to avoid him. To remind him. But in this patient, if he is communicable, then I will tell him, when you are watching TV, you can take off the brace. So we use the term chondromalacia patella to the patients. Yeah, what's your treatment? Please answer me in general orthopedics view, not your personal view. But what do orthopedics people treat chondromalacia, anterior knee pain? What's our approach?
So it depends on how severe it is. The early grade you
General
use,
orthopedics, not personal.
no, of course. And so the early stage you use conservative treatment, exercises, some painkillers, modification of wearing braces or not braces but some support of sorts, offloading. As it gets more severe, you use offloading devices,
And then?
now very severe you consider doing debridement. But beyond that, I don't know. Because I don't know
The
how
general
severe
orthopedics.
So let me see, I don't
This is something I wanted to point out. We are helpless in patella problems. Like in the knee ACL, I pointed out, I said number one, there's ACL, number two, MCL grade 2, meniscus tear, etc., etc. With the patella issues, although there's evidence, but the common orthopedics all over the world, including US, UK, Turkey, Europe, has a blurred approach. Nobody wants to see a patella patient at the end of the clinic day. They are tiring. You immediately think, do they have a problem, psychological problem or not? One of the reasons is we are not able to classify the problems into the language we orthopedists understand. We are mathematics people. We want 1, 2, 3, and then solution. This is equal to greater than that, less than that. That's our terminology. So this is what we need in the patellofemoral issues. We need to classify the problems. And with this talk, that's what I will try to do. So, can you see, is it full screen or? So you know me by now, and is it full screen? So this is Istanbul again. This is the old Constantinople part, and this is the Hagia Sophia, turned into mosque in 1500, and then into a museum by Kemal Atatürk, and then to a mosque by Erdogan. So this is the very important slide. When these patients come to us, it's a spectrum. There's no anatomic abnormality, but there's anterior knee pain, and then there's patellar dislocation. So these patients, sometimes they have both. They have patellar dislocation and anterior pain together, and they tell their problems. If you cannot diagnose the anatomic aberrations, then you treat the patient as go to physical therapy, let me do you PRP, etc. But this patient has an objective problem. It dislocates. It's an objective issue. And they come to us with, I sit long time in the movies and cinema sign. I have a problem driving long hours and staircase walking up and down. There's crepitation. I feel like it's dislocating. I'm sure you have the same term. Is it dislocating? No, I feel like it's not dislocating because afraid of surgery. But this is the critical point. If it's dislocating, I will do surgery and it will be good for you. If it's not dislocating, subluxating, I won't do surgery. So, but the patients cannot tell. Very difficult to help. So look at this patient's knee. Look at the patella. I'm not sure how well you can see, but because of the femoral, I will go back again. Because of the femoral intoing, the patella remains outside. The femur goes in, but the patella stays outside. And this is what happens. during this motion. Actually, it's a wrong image I put. The patella stays and the femur goes. So this is what they feel because they have femoral anteversion. There's no problem with the knee. The problem is the femoral anteversion height, and this happens. So body forces act on the knee, the Q angle, etc., the rotational alignment, all these factors, and like I said yesterday, there are mechanical, physical measurements at work in the knee. The red line on the right hand side is the weight center of the body. The black dot is the center of the knee, so it's a comparison between the patella and the distance to the weight-bearing line. With hip flexion, it increases, so it goes up to 7 times from the center of the knee to the patella. And this is a staircase walking. What I want to show you with this video is the difference between why patients have problem more when they are going down. You say, do you have problem with mechanical access, heel valgus? We notice all these. We are sharp people. When a patient walks in, we understand what's going on immediately. It creates something. We just have to note them down. And look at this now. This is how the knees are. Patella is here, quadriceps. And when the quadriceps contracts in a valgus knee, it pushes the patella laterally. And in the sagittal plane, most important thing is the patella position. It may be up, like I hope you can see it in the upper picture, low in the upper picture, patella infera, or patella alta, as in the lower picture. This you have to do in every knee patient. The most frequent one is this, like this patient, I hope you can see it, looks like she has straight legs. When you look, I especially took this picture from the patient's point of view, looking down at the legs, perfect straight legs. But there's femoral anteversion. This child, this lady, when she was a child, she would sit like this. And then when you tell them, once you find out the femoral anteversion, you tell them, when you were a child, could you sit like a tailor? Tailor sitting. That's what it's called, that they can sit like this. They sit like this because of femoral anteversion height. And they say, yes, doctor, I was like that. I say, that's why you have this knee problem. And then they relax. Because it's not because of trauma, it's not because of other things. Then she needs stretching. Otherwise, and it corrects. And don't forget, when the patients come with pain, some of their complaint is, will I be worse? Will these go to another place? So we have to understand, and nobody becomes crippled because of anterior knee pain or femoral anteversion. So we have to tell them, this is the worst it will be. And they relax. And the ligaments, in some patients, hyperelastic patients, it's an issue. And then there's the cartilage issue. These are all elements. So I told you about, not specifically, Q angle, cartilage, this and that, and valgus, about maybe 20, 30 different parameters that you have to look for in a knee, which you already know. It's not new to you. But they are not all measurable and practical and selecting the patient that we will operate on. This is our job. We are orthopedic surgeons, so of course we have to understand. We have to divert the patient to physical therapy, etc. But we have to find the patient that we will operate on. It's a shame if we cannot diagnose the patient that will be better by surgery. This is our job. If we cannot treat a patient well that doesn't need surgery, it's not our primary job. There's the physical therapy doctors, conditioners, etc. But finding the surgery patient, we must do that. We have to select the correct one. And these are the parameters that we have to know the TT-TG distance. We have to know if there is trochlear dysplasia or not. Some secondary factors. Patella alta and patella tilt. These 5 things you have to know. So the TT-TG distance, this is a normal excursion of the patella. With flexion, it goes down, and with extension, it comes up. And there's about 10 centimeters of patella going in the groove, up and down. But I hope you can see this again. This is a CT image. Look at the tuberostas tibia and look at where the patella is, and imagine the flexion and extension. So many different ways of the patella tracking, not always within the groove. So it's bound to hit left and right, mostly to the lateral, of course. And J sign is the one that is most known to it. And we look at a J sign, and it's a reason for surgery. And I will not go into how to do the surgery, but it's because of the lateral hump that the patella coming towards extension flips to the other side, and when coming into flexion flips back into the groove. So you have to do a trochleoplasty for this patient. Trochlear dysplasia, the sulcus angle. It's called merchant angle. The groove has to be deep enough in 45 degrees of flexion so the patella will move. And de jure classification, David is a very good friend of mine, and he has described this long time ago. And so A, B, C, D types, you have to know these. It was what are the minimum requirement for evaluating the knee, patella. Look, with a simple X-ray, you can tell so many things. You can tell the crossing sign, shallow trochlea, supratrochlear, superior, double contours of lateral convexity, and cliff in the patella. So by simple, correct X-ray, where the condyles overlap, especially the posterior condyle, it has to overlap. So it wouldn't be practical that I teach you the crossing sign, trochlear, super. You have to look at these and understand what crossing sign is. It will create you, I'm sure all of you will understand, because we are three-dimensional thinking people. You will understand by a simple lateral X-ray, you will think of it immediately. Patella alta, I believe, is the mother of all patella issues, problems. Look back to your X-rays. I look back at the X-rays of 20 years ago. I operated on a patient. I missed the patella alta. I wasn't aware of the problem of the patella alta. So patella alta is very common, and there's a dilemma. Patella alta people jump higher because of the calcaneus distance. When it's longer, you can run faster, and patella alta has the same consequence. You can jump higher. So all the volleyball players and the basketball players, they have patella alta, and those are the ones that come with patella issues. So look here. This is the excursion of the patella. So when it's in when it is in extension, if the patella is way superior, it will never reach the groove in 30 degrees of flexion, and that's where the dislocation occurs. The patella does not dislocate every single. It does not dislocate, or it doesn't bother. But at 30 degrees of flexion, it is painful. Very painful. So I will show you another drawing. This is how the patella alta is, and this is where it should be. To place it within the groove, in the flexion. And there are variety of height measurement. I use Caton Deschamps. You can look these up, and you will find the most suitable for you. And also contact position of the patella with the femur is important. You have to note these. And patellar tilt. It really is a sign of lateral contracture. Patellar tilt, and it's not as important, but it is important. It shouldn't be more than 20 degrees. And then there are these types. What is the most frequent thing we say to a patella patient, anterior knee patient? What do we tell them? I will answer for you. You should say, strengthen the VMO, right? But some patients do not have VMO. They don't have muscle fibers. And these are the types. The type 1 has VMO coming only to the superior part of the patella. Those are the patients that will recover from strengthening. But those are the ones that do not have knee pain because their patella is centralized. So this is very typical. Once you think about it, these are the patients that have muscle bulk close to the thigh. Their quadriceps comes in a triangle and touch the VMO. There's no VMO. So we tell them, strengthen, do exercise. Doctor, I'm doing exercise, nothing. Of course nothing will happen. There's no muscle to grow there. There's no muscle fiber. And then there's the middle type, but look at this type. It's all the way down to the half of the patella that there's muscle fibers. So these patients will recover, but they usually don't have. The patella shapes based on the function, which is trochlear dysplasia, forces the patella to function in a certain way. So the patella shapes, and you know there are types of patella. If the groove is correct and the normal VMO, then the patella will be in the classical shape. So patella doesn't grow on its own. It grows in shapes in relation with what the knee is like. So you have to evaluate it together. The congruence angle and the patellar tip should be measured. So these are the 5 elements. You should not miss these. So if somebody asks you the TT, TG distance of a patient, you have to know. You have to know. As an orthopedic surgeon, we have to know. We say, so there is no need for surgery, then it's another issue. Again, it's our issue to treat patients conservatively. I'm not saying it's not our problem, but it's a difficult situation. So I recommend that we we have to select the surgical patients properly. That's my point. Don't get me wrong. So this is a very good algorithm. Did you guys must have received a link of this presentation from the organizing committee. So you should look at it tonight just to get an overview. And this is one of the things that you should remember. So the patient comes to us with recurrent instability. We take the X-rays and MRI and we look at anatomic abnormality. If the tibial tubercle is lateralized, which means TT-TG distance is more than 20 millimeters, then we do distal realignment and medial patellofemoral ligament reconstruction, like in this case. If there is patella alta, Caton Deschamps index is more than 1.2, then we do TTO distalization to normalize the patella height and MPFL reconstruction, like in this case. If there is trochlear dysplasia, you have to think very delicately, because trochleoplasty has a lot of complications. It's not set yet, and it's a one-way street. So in these patients, David himself, talked to him recently, prefers to do an MPFL reconstruction, just like a empiric surgery, just do something little that doesn't create a situation, big disaster, but to help the patient. And then if there's patellar tilt, work on the lateral release. These are very few of the patients. Lateral release has very limited indication. So never do lateral release on your own unless in this case the patellar tilt is more than 20 degrees and all the other patella alta, TTTG, dysplasia are normal. If they are all normal and there is patella tilt, which is very rare, then you do lateral release. So the anatomic parameters are within normal limits, so it's a normal knee by anatomy, but it's unstable. You feel it. There's objective evidence that the knee is dislocating. Then, just like ACL, this person had an MPFL tear at one time, so you reconstruct the MPFL. You don't have to have an anatomic abnormality to dislocate your patella. The medial structures tear, dislocate, and you do this. So I will give you some examples. This is a case, 33 years old, 19 years ago. It's now 23 years ago when I first put this, I prepared this 2-3 years ago. I did just lateral release and arthroscopic debridement. But look at this. There's patella alta and trochlear dysplasia in this patient. So wrong. But good thing that I didn't try anything more complicated than that would cause complications. So right now, this patient comes to me, distalization of the patella and maybe MPFL that I would decide during surgery. This patient, severe anterior knee pain. 36 years old. It has patella alta, trochlear dysplasia, and degeneration involved with this. So I only excised the bipartite patella. I will come again. Look at the anterior part. And this is, the patient got better. He couldn't go up and down the stairs. Now we can do that. But that was my aim. Limited aim for this patient. He came too late. So this patient, 32-year-old female, anterior knee pain, feeling of subluxation. So she doesn't have patella alta, but she has type D trochlear dysplasia, and she has J sign. So this is flexion, it's dislocated. When coming into extension, it goes out. So within the last 20 degrees, 30 degrees of extension, the patella draws the J sign. Like this is a schema of what's going on. So in this patient, I medialized the tuberosity tibia, and then I reduced the hump of the lateral condyle. So in trochlear dysplasia patients, the trochlea is high in the lateral side, so when the patella is going up, it dislocates from the lateral side. In extension comes back in again. So it makes this J sign. After surgery, the J sign is gone. 37-year-old female, knee pain, unstable. Look at the muscles. She doesn't have VMO. So strengthening will not help her. Unstable feeling. So the patient she doesn't have patella alta, but she has subluxation. So in this patient, I did the transfer of the tuberosity tibia, MPFL, and there was cartilage issue, grade 4 cartilage. So I turned down the patella. Out of the cartilage there, I missed the cartilage. I put it into defect, and then I periosteum from the tuberosity tibia. I saw over it. And this is the patient after 1 year. This is the knee that I don't know if you can see her face, but she's sending this message as a joke to me. Like her knee, other knee, non-operated knee hurts very much, but the one operated on doesn't hurt. And there she's showing that. And this is a patient, 33 years old, male, knee trauma. So there's isolated MPFL problem. And once you go in, there's hematoma and everything. And you do the MPFL reconstruction, I told you yesterday. It's perfectly reduced and everything is fine. So thank you for listening.
Thank you, Professor. So we'll have a slight change in the program because speaker at 12 must speak on time and he's speaking from Germany. So we'll skip some presentations. So we'll have a brief presentation on evaluation of the multi-ligament knee, and then the very brief presentation on complications of ACL. Then we have a panel discussion and tea break, so that we try to push some presentations to the afternoon, and the ones we don't push, we can cover them in some of our webinars. So some of them are straightforward topics we don't have to belabor on, but we want the guest speakers to give all the presentations and enough time for discussion. Dr. Nurani?
I don't know if it's loaded, the presentation here.
Has it been loaded?
Dr. Deng, she's a senior house officer with us at the Arkan Hospital. She will present the talk on multi-ligament injuries clinical evaluation. Later on, Dr. Lutomia will talk about the surgical aspect. Dr. Deng, please.
Hi. 10 minutes, okay.
You sent it.
It doesn't have it.
No, the one I gave you to put in the morning. Knee present Isakos, it was written knee. Yeah.
Good morning. My name is Chai Deng. Thank you for this opportunity to present multiligament knee injury clinical evaluation. The multiligament knee injuries or knee dislocations are defined by clinical or radiological disruption in tibiofemoral congruity. It may also involve at least about 2 injuries to any of the ligaments in the knee joint. Now, knee dislocations have they're a rare type of injury in orthopedics. They account for about less than 0.02% of all orthopedic injuries. Now, compared to hip dislocations or injuries, they are a little bit on the lower scale. They can be up from 2 to 29 cases per million annually, as compared to more than 100 cases per million annually in hip injuries. Now, the difficulty with assessment of knee dislocations is that about 50% of these dislocations tend to self-reduce. They may be caused by high energy mechanisms or low energy mechanisms. So the most important thing is when a patient presents to us in the emergency department, we need to be able to evaluate this patient fully. For example, a polytrauma patient who shows up to us, while we're doing our advanced trauma life support evaluation, while we're looking for head injuries and all other injuries, chest injuries and whatnot, we need to also look at our knees. We may miss out on these injuries due to the fact that about 50% of them tend to relocate. It has been shown that Morbid obesity is a risk factor for knee dislocations. Knee dislocations have been classified into two types. The first one is a Kennedy classification, which looks at displacement of the tibial component. So we have the anterior displacement. Sorry. Just a minute, sorry. We have the anterior displacement that is more frequent, more common. It accounts for about 40% of all knee dislocations. The mechanism is mostly due to hyperextension of the knee joint. There may be injury to the PCL. Type 2 is a posterior dislocation. Now, this is commonly seen in high-energy injuries, like dashboard injuries. So the tibial component is posteriorly dislocated. It may also involve an ACL injury. We have a medial lateral dislocation and also a rotatory kind of dislocation. Now, the Kennedy classification, we cannot, it poses a challenge because these knee dislocations tend to relocate by the time the patient arrives at the accident and emergency. So we have a second classification called the Schenck classification that looks at the severity of ligamentous injury. We have the type 1 dislocation that may have either of the cruciate ligaments intact. The type 2 knee dislocation may include a bicruciate injury with the collaterals intact. Type 3 has a bicruciate injury with at least one collateral ligament injury. Now, we have a denotation that is type 3M, which denotes for medial sided ligament injury, and type 3L for posterolateral ligament injury. Type 4 has bicruciate injury with both the collateral ligaments injured. Type 5 has a fracture dislocation. Now, the Schenck classification also looks at neurovascular compromise. So it denotes for arterial injury with a C and an N for neural injury. Most commonly, these injuries may involve the common peroneal nerve and the popliteal artery. Now, in emergency rooms, when the patient presents to us, we need to do a very thorough evaluation of this patient. So, number one, the patient comes to you, may have knee pain or may have been involved in a high energy sort of injury. So while you're doing your ATLS protocol, you have to look at the patient. You have to take proper history. Ask them what happened, or whoever brought them in, what happened, what mechanism of injury was involved. Any pre-existing maybe coagulation disorders, was there a prior attempt at reduction of this knee? So if you can evaluate for sensory deficits, is the patient having paresthesias and is not feeling anything on their leg or feet? You have to assess for vascular status, assess the dorsalis pedis or posterior tibial pulses. Are they symmetrical? Are they present? Then after that, you need to have immediate radiography. Simple AP and lateral imaging, X-rays are important. Now, after this, you'll be able to classify your dislocation. Immediately after your radiographs, if the knee has not been reduced, this patient has to have reduction of the knee immediately. This can be done under conscious sedation at the A&E. If it is not possible to reduce the knee, then the patient has to be taken to theater, and reduction has to be done under anesthesia. Now, after reduction of this dislocation, you still have to evaluate injuries to these ligaments. So you may do examination of the different ligaments for the integrity under examination under anesthesia. After your reduction, the knee can be mobilized using a brace. Now, during your reduction, if you notice that the knee is not stable after reduction, you can then proceed and do an external fixation. If reduction is not possible, still the patient will require open reduction. The post-reduction protocol involves further evaluation of other injuries. Number one, you need to do x-rays to assess realignment of the tibia and the femur. Then CT scans can be done as well to assess for maybe fractures that may have occurred. And CT angiograms can be done, especially in patients who have vascular injuries. MRIs are important in evaluating soft tissue injury, the ligaments and all that, such that you may be able to have better options of repair later on. Regular monitoring of pulses and ankle brachial indices are done. So now this, sometimes this is quite confounding because there are patients who may show up, they will have good strong pulses bilaterally, but if you do an ankle brachial index, it may be low, it may be below 0.9. So these are patients that you need to further evaluate. You need to do regular monitoring of their pulses. You can keep them over for about 72 hours, 24, 48 hours of monitoring of these pulses. Patients that you note may have a vascular injury, of course, will then require further evaluation of the extent of injury. They may need a CT angiogram, or they may need regular angiography while they're still on table when you identify the injury there. Now, emergency surgical interventions are usually determined by the kind of injury that you have identified. Vascular injuries obviously will require emergency surgical interventions depending on the degree of injury. Open knee dislocations will need to be fixed there and then. Knees that cannot be relocated, that you fail to reduce them reduce them close, you have to do open knee reductions. Those that are unstable after reduction need at least external fixation to maintain that alignment. Those that have associated unstable fractures may need those fractures to be fixed then. And those with compartment syndrome need to have a release. The patient may present with, they may present early or late, or they may come with a grossly deformed knee. Others may come with the knee that has already relocated. Others may be open dislocations. Others will come as close dislocations. All those have to be evaluated such that you make an informed decision on what definitive management you'll plan for. Now, on our examination, we look for any swellings, any deformity, abrasions, ecchymosis, gross instability. Clinical assessment of the different ligaments may be done under examination under anesthesia. So you have to assess for all the different ligaments to see whether there is injury and hence need for repair or reconstruction. Vascular injuries, like I said before, needs to be assessed because this puts our patients at a high risk of limb loss, that is amputation, if they are not caught early, especially for those patients whose knees have relocated. So the injury may be occlusive or due to disruption of the vessel itself or intimal tears. Intimal tears may lead into occlusive vessel injuries. Now, nerve injuries, a patient comes to you and tells you they're having paresthesias on their feet or legs. This should also, they should alert you on a high suspicion of a vascular injury. They may come at a go. We have an algorithm on the management, the evaluation and the management of the acute knee dislocation. Initial evaluation and radiographs important, reduction if possible at the A&E under sedation. If not, patient has to be taken in and reduction is done. Then further evaluation of other injuries should be done as well. Now, we have emergency operative treatment for these dislocations as well as acute phase treatments. Now, in the emergency operative treatments, we have to look at the knee. Is it irreducible after the first attempt? If it's irreducible, then we have to do open reduction. Those with open knee dislocations may need debridement, lavage, and collateral ligament or capsular repairs and closures with soft tissue cover. They may need external fixation as well. Those with unstable knees, post-reduction, will also need to have external fixators. Those with associated compartment syndrome will need release of the compartment. And those with associated vascular deficits may need a vascular surgeon to have a repair done. The acute phase treatment may be staged, may be a single stage operation or a staged operation. Single stage operations may, now this I think mostly depends on the surgeon, and there are so many controversies under the acute phase surgical management. I think Dr. Lutomia will shed some more light on it. So there are those who prefer open stage repair and augmented repair of collateral ligaments and reconstruction of the cruciate ligaments. The staged surgery may involve repair of the ligaments and then the arthroscopic repair of the cruciate ligaments. Or you can have acute phase immobilization and you have delayed arthroscopic repair of the cruciate ligaments and then open reconstruction of the collateral ligaments. The controversies, like I said, Dr. Lutomia will shed some more light on it. In conclusion, with the multiligament knee injuries, we have to do a proper evaluation at initial contact. We have to always have a high suspicion of knee dislocations in especially polytrauma patients. We have to keep in mind that 50% of these dislocations may have relocated, and we have to assess for other injuries, especially the neurovascular examination, very important. So the importance of being a member of Isakos is that we are availed with free resources like my reference here. So thank you all.
The next talk will be by Dr. Oyo on complications of ACL surgery.
Complications.
Inaonyesha notes. Inaonyesha notes. Kwa nini kwa screen naona hizi? So ni okay, sawa. Okay. I need to morning everyone. As Dr. Ponda said, I'm Dr. Oyowere. I'm a military orthopedic surgeon. My presentation today, I'm very lucky because Prof has touched on most of what I'm going to say and given it more weight. So I'll basically just put them in a table form and show you. So, okay, the first two slides, I think, are what we'll base the discussion on. Then the rest of it will be quite short because it will just be a series of tables. So the other thing I avoided was to put the general complications of arthroscopy. As we heard from the talk yesterday, for example, the damage to the cartilage because of the sharp instruments involved. So my talk is focused on the ACL. So what do we do to avoid the major complication? Okay. Oh, thank you. We need to ensure range of motion and ultimate knee stability. Again, we'll see some of the complications arise when we don't examine delicately and also scrutinize the imaging. Then anatomical landmarks, again, we've been shown by Prof. Graft harvest, will come to the complications of that. And if we do it meticulously, we at least reduce the complications. We need to tension the grafts. And we need to use a sterile technique to avoid infection. When these complications occur, we need to be able to recognize them early enough, and when necessary, we do surgical reconstruction. That's just a list. So I'll now go to the specific complications. Again, one way of reducing the complication, and as we were seeing yesterday, in terms of the learning curve, yeah, is making errors in diagnosis and judgment. So make sure the diagnostic process and the decision to operate and how to operate are well thought out. Firstly, we can get postoperative stiffness, which can happen if you do the surgery too soon. But as Prof has told us now, the knee will talk to you. Yeah? The knee will tell you not yet. So for example, as he mentioned, before you get full extension, a 90 degrees flexion, then it's not advisable to do it. You detect it by the range of motion postoperatively. And when that happens, the only thing you're left with is physiotherapy, maybe MUA. And if all is not working, then you can go and do another scope. Again, the meniscus and the articular cartilage. Now, most ACLs, for example, if we delay the surgery, then you're likely to get a meniscal tear. Also, you're likely to get articular cartilage damage. So this can happen from performing the surgery too late. We can prevent by advising the patients. If you advise the patients on the complication and them accepting that they are aware of what might happen and sign for non-operative treatment, then because of the instability, bracing may help. Then MRI, just to imaging to help us confirm the instability. And then the solution is to treat the lesions as they arise. Now, this one can happen. In a primary ACL situation, it should not happen because now that's the native ACL. Yeah, but in a revision, it can be intact but inappropriately placed. We'll come to that. But if you go in and find the ACL is intact, it's better you abandon the surgery, let it stay. Now the other thing is if sometimes before you operate, you want to do a clinical examination, correlate with MRI, and if you are sure the ACL is torn, then you harvest before you scope. Sometimes I do this, it has never happened to me. When I was preparing this, I just thought, suppose it happens now, you've harvested, then you go find the ACL is intact. Yeah, sometimes you find the ACL has gone and attached to the PCL, but the lateral wall is empty. So in that case, then you just prepare it accordingly and replace. Okay. Now, if the reconstruction fails, the pain may be persistent and you might also get valgus instability. What would cause this? Suppose there was an MCL tear as well, possibly grade 3, which needs repair and it was missed initially, or there is a further injury to the posteromedial complex. So we prevent by, again, careful exam, valgus at 0 and 30, and then doing the anterior drawers test and scrutinizing the MRI. How do you detect it? Again, on examination. Then you check the rotatory instability. And then if you found it, then you brace. That's for the MCL, not for the ACL. You brace. And then if surgical reconstruction is required, you go ahead and do it. Again, varus, just almost like the valgus, but now on the opposite side. Again, a missed posterolateral corner injury, exam, MRI, and then mostly for the posterolateral corner, you need to reconstruct or repair. The MCL, partial tears, or mostly femoral sided, you can brace and wait. Now, again, you can have an additional diagnosis of a missed meniscal tear. And so you go, you do your ACL very nicely. But again, as we've been told previously, the surgery is very good, the ACL is good, but there is persistent pain. So again, history and exam. Then you can use a posteromedial portal or a Gilchrist view where you go between the medial condyle and the PCL and try to look at the posterior side of the joint. One other way, I don't know, maybe the other colleagues can help me see if it can be validated. You try to push the probe posteriorly. Usually, if it can go through past the attachment of the meniscus, then you suspect there could be a tear. If it can't go through, then you slide on the posterior condyle, yes, and then if you can slide it past the root, is under the root, then you suspect there could be a tear you've missed. So again, this I put in red. I hope it's visible in red, because this does not settle the debate on which tears to repair. But as a general guideline, red and red-white, you can repair and do the meniscectomy, the partial meniscectomy for the others. The picture there is just showing a tear of the posterior horn of the medial meniscus. So, yeah? Yes. A root tear, which we can miss and get the symptoms. Now, graft harvest depends on, the contaminated graft would occur with any harvest, whether it's hamstring or BTB or quadriceps. It's also something I would dread seeing happen, but we need to be extra careful either way. So if it happens, unfortunately, now you have a few options. You can try sterilize it. Then you can harvest the contralateral one. In scenarios where allograft is available, they can use. That is not available in our setting. Again, it's obvious during surgery if the graft falls. So patellar fracture more commonly occurs with either the BTB or the quadriceps tendon. So the way to avoid this is to don't make the cuts vertical at an angle, so that at the end you have a trapezoidal graft. And then after you get the graft, you examine, and if you notice that the edges are rough cut, then you can bevel them. You can also get your bone graft as you prepare the bone, the tibial and the patellar sides. The bone you have left, you can use it to plug. Then if you feel you are at risk of a fracture, then you can do protected weight bearing. Now, if you are harvesting hamstring grafts, usually there are very many attachments, especially once as you go along, as you do more, then you are able to easily isolate the semity and the gracilis. But when you are harvesting only, when you're like for us, we do a lot of all inside. So sometimes we try to harvest the semity first. We see if it will be adequate. If it's not, then we get the gracilis. So if you don't release the attachments, maybe to the gastrocnemias, you find some to the sartorial fascia. Sometimes there's fibrosis and you get not the classic attachments we see. So you try to release them, and then you strip. You strip. You go with a controlled motion. You try to make it in line with the line of the tendon, and you try to make it. You don't pull your stripper away too far from the bone. You make it. Try to make it lie on the bone. That way you are more likely to succeed. Yeah. And then how do you check it? You examine the tendon length, and then there's sometimes if you are trying to release and you can't pull out, you try pulling out with the knee flex, you are only seeing you have 1 centimeter. So you have to go back in, try to release, make sure you have the right tendon before you go and strip. Sometimes after you've tried stripping, if the first one is transected, usually if you had gone for the gracilis, you can find the semity a bit better. I don't know the other colleagues' experiences, but sometimes now you can't get the other one. So it's good if you suspect there is an impending inadequate release, go back and start afresh. Then if it happens, again we don't have an allograft, we have to think of an alternative graft. You've prepared one knee, so your options are also limited. Meaning you go and try to prepare the other side, it's a bit tricky. So the other thing is you can plan for another day. So flexion weakness, again, as we've seen, more likely you're more likely to get extension loss than flexion loss. But if you harvest the hamstring graft, again, eyeballing to see how much of the muscle you've removed is tricky, but that's what can happen. So when you're harvesting, as you've said, you avoid plunging. You go with a controlled motion. Then Now, usually, most athletes can work with hamstring grafts, but like the hurdlers, the ones who now require maximal power with high flexion, then those ones it's safe to avoid the hamstring graft. So the detection, as we've said, you see excessive muscle, again had to decide, but the treatment is a physical therapy. You focus on hamstring strengthening. Yeah, the saphenous nerve, I should have put an anatomy picture, but yeah, you can injure it because what the infrapatellar branch just comes out around the pes, so it's easy to injure it during harvest. Again, you make sure, what I do, just go through the skin. After that, I make sure I see everything I'm touching, whether it's a vessel, a nerve, and or a tendon. Again, for us, the tourniquet helps. I don't know if someone would be doing it without a tourniquet. I think the risk of injury would be much higher. But generally, you do careful intraoperative technique. You do blunt retraction. So the symptom usually is increased sensation on the medial aspect. So I think there's nothing much structurally you can do once it's injured, apart from observing. You counsel the patient, and you can try desensitization therapy. Sizing is also tricky. You can have a tunnel and a length mismatch. So that if you have a BTB that is too long, the interference screw will not be able to be used. And if it's too short, then the bone-to-bone contact will be less, and the cortical fixation will be compromised. So how do you prevent it? You measure the bone plugs appropriately, and then you plan your tunnels. Detection, usually you'd see the graft protruding out of the tibial tunnel with the knee extension. It means the graft is too long. So in terms of how do you handle the situation, if it's long, you are lucky. You can recess it or shorten the bone plugs. If enough bone will remain. Again, we've said if it's too short, there won't be cortical fixation. Then if it's if the graft is too short, you try to augment or use additional fixation. Graft width, again, this is obvious, as Prof was saying, it's 1-2. You see it's too wide, it can't go in. You see it's too small, yeah, it can be loose. So again, if you have too much soft tissue in the joint, the motion may be compromised. So how do you handle this? You measure the bone plugs before you drill the tunnels. If that happens, then you can detect it by using scissors or when you are attempting passage. Then what is the solution? If it's too big, again, you remove the graft from the knee and trim. You can use the trimmings to graft the patella. And then soft tissues can be trimmed, or notchplasty can be done. So alternative fixations, now you can go for endobaton, staples, sutures. But what I noticed with the endobaton, if you try an endobaton with a BTB, because you use sutures to advance it. So sometimes turning the bone using the suture to pull can give you a real headache, but it's an option. It's an option when you have a bone plug that is too small. Again, now there was a lot of emphasis today earlier on the placement and fixation, the position. So I may repeat, or if I see there is I might just gloss over what Prof has already gone through. So if the tunnel is too anterior, we as you are shown, the 40-60, if it's too anterior, there will be loss of extension. So, and then the way you can do it is to, again, you are shown how to use the lateral meniscus as a reference. And then in case it's available, you can use intraoperative fluoroscopy. So again, detection, you can see the graft impinging when you extend. Then you can do the radiographs or MRI, and you'll get limitation in knee extension. So how do you handle that? You can expand the tunnel and fill in now, because the tunnel will be too large. You fill it in with the supplemental fixation. If it's too posterior, again, the tunnel will now be vertical, and you'll get poor rotational stability. So you are likely to get PCL impingement, and it can fail early. So how do you deal with this? Tibial guide. If you are using the tibial guide, you place it. You avoid placing it against the PCL. Again, it shouldn't go towards posterior to the tibial spine. Yeah. So if you are using fluoroscopy, you make sure it's not past the middle. This has already been explained. So again, just the solution, you can consider expanding the tunnel, and again using supplemental fixation. So this is just a picture showing the notch. This is a picture I've borrowed from one of the journals, showing a well-placed graft, yeah, with the notch, with the knee extension, so you can see the notch clearly. For the femoral tunnel, it could be again too anterior, which will result in loss of knee flexion and early failure. So again, this was shown pictorially by Prof. He showed us the residence ridge along the Blumenstadt line, and then the other ridge dividing the residence ridge. So if it's anterior to the residence ridge, then you know it's too anterior. If you're using a radiograph, again you can see. Then if you detect it early, you can expand the tunnel and use maybe now suspensory fixation or rather than an aperture fixation, and then you can consider revision for normal knee motion. To posterior, you can get blowout, and now you won't be able to fix. Once you get blowout, okay, some of the reps say they have a way you can fix with the suspensory fixation, but I've not seen it. I guess for me, a blowout would just mean I have to use an alternative femoral fixation. Again, you can drill at least one diameter away more anteriorly. But this compromises what you are doing, because you see you want to go just posterior to the residence ridge. So if you move anteriorly one diameter, it means your graft has shifted anteriorly. So again, your fixation is compromised. If it's too vertical, there's going to be rotational stability. Then the way you'd see this at 12 o'clock, then at 90 degrees of flexion, you'd sit at 12 o'clock position, and then the radiographs will show the vertical tunnel placement. So for me, I normally drill from the anteromedial portal. Either if you're using the all inside, there's a guide for that, or you can try to go with a wire. So if you're using if you're drilling through the tibial portal, there's a picture I had. If you're drilling through the tibial portal, then you have to make sure you do proper flexion beyond 90 degrees. Patellofemoral pain again, and the loss of knee extension. This happens when the graft is fixed in excessive knee flexion. So we can always fix grafts in extension. So between 0 to 30, you can just go for 0 to avoid all these complications. So you get a flexion contracture, and you can do an MRI to rule out soft tissue impingement. Again, when this happens, physiotherapy, casting or dynamic splinting, and then if you have the cyclops, then you can remove it arthroscopically. Excessive notchplasty, again, can cause articular cartilage damage and patellofemoral dysfunction. So you can survive with the limited non-notchplasty, at least for you to get your anatomical parameters proper. Most cases you need to do possibly a soft tissue notchplasty, at least of the posterior aspect of the lateral condyle. So you can use an accessory portal to see the notch and avoid the excessive excision. So the way you can see it, check the patellar tracking and the width of the notch. So the solution, just place your graft properly and hope for cartilage, not exactly regeneration, maybe replacement. So this is this applies when you are using aperture fixation in terms of an interference screw. If the screw and the graft are not facing the same direction, then you're unlikely to get adequate fixation. So one way of preventing this, you use the same portal, and then you can hyperflex the knee when inserting in the femoral tunnel, and then you can also use a guide wire. So if you do an X-ray postoperatively, you can detect the divergence, and if you have a problem fixing the interference screw, then you suspect there might be a problem. So if you noticed intraoperatively, you can adjust the screw and get the direction right, and then you can consider supplemental fixation. Again, because it won't be so stable, you can modify your postoperative protocol. This is just a picture. The logo moved, sorry. The logo was meant to be on this corner. So this one shows now if you drill the tunnel using transtibial versus anteromedial, this instrument is going through the anteromedial portal, while the tunnel here, sorry, the tunnel was through the anteromedial, while this is going through the tibial tunnel. So you can see that divergence, and that when you are using a screw fixation, it will become a challenge. Post-op infection, again, I can say I haven't come across a study locally that gives the rates of infection. In why Why do my rates are okay? My rates are near yours after using vancomycin, near zero. Yeah. So, but it can happen. Be careful about what is going on around you. Then you can use waterproof drapes, and then for allograft, you use trusted sources. We don't have that again. Diagnosis is by knee cultures, and then the treatment, again, how we handle infection. Sorry, I'm almost done. So stiffness, just to say, we can see loss of terminal extension early, within 2 weeks. Flexion, flexion, we pick it later, around 6 weeks. So rehab, casting, MUA, yeah, and then if it's refractory, you can do surgery. Patellar fracture, again, we've mentioned it. Solution is protected weight bearing and surgery for displaced fracture. That's the end.
Thank you very much. Thank you, Dr. Yo. I think we will keep your questions. So we'll take a break for tea, and then we shall have a discussion on patellofemoral, and then we might have one presentation before we have one foreign speaker. So I think let's take a tea break before Prof can be able to answer any questions from the previous presentation, and then Dr. Yo will also be at hand. Thank you.
Online presenter is from Germany, from Munich, Dr. Jacek Klusic. He's going to present his talk on advancements in cartilage regeneration. Do we have him online, please? IT? Hello, Dr. Jacek, can you hear me?
Jessica, can I say you? I hear you guys.
Right.
Hello.
Hello, yes. Thank you very much. So your first talk is actually on ACL reconstruction and repair, right?
Right, yes.
Absolutely. So you're welcome. You can take the lead. Can you allow him to screen?
Yes, I need to get the allowance for sharing my screen, and then we can start in a second. Because it says I'm not allowed to share my screen, so probably we need to switch something.
Yeah. We are on it right now.
Okay. So now you should see my screen, right?
We are on, yes, we can see. Please.
Okay, great. So if you hear me well and if you see my screen, and I just start over, and yeah, I want to say hello and welcome from my side, from Munich in Germany. Thank you for the invitation, for being with you at the East African Arthroscopic Association. Thank you, Dr. Ovinga, for the invite. And yeah, I'm speaking to you.
Recording in progress.
I'm speaking to you out of Munich, as you see on the picture. We have still some snow in the background here in Bavaria. So yeah, that's actually what you can see for today. So I proceed now with my presentation. Please, if you like, ask something, and we have for sure some time to discuss at the end. What I would like to do is I would like to give my ACL talk and then proceed with my cartilage repair talk, and then probably spend an hour with you and then go back to my daily practice, if it's okay for you guys in Kenya. So I start now with my presentation. Thank you very much. What did I want to say? I just wanted to have a look on our sports people, sports professionals, but also the very active non-professional ones. And when you see the pattern of injury, Of course, there is some question mark. What really is to address in a knee when you have an injury like that, right? It's a rupture of ligaments. Is there anything else? What is the reason and what is the rationale of treatment in our ACL surgeries? And I borrowed animation from my good friend Arthroscopy. They have it on their website, and this is a fantastic kind of principle where you see when you have your ACL, ALL, and ACL as the lateral structures for knee stability, and during a translational tear, what happens is, sorry, it stopped. What happens is that you see through the translational forces you have not only ACL tear but also the ALL may be affected, and root tear also happens on the back side of the knee. And if you focus on the lateral side of the knee, that is exactly what we should keep in mind, and we see a lot here in our practice every day. Of course, there's also a posterolateral corner on the medial side, and there might be a posterolateral corner tear as well in the more severe cases. If you look from the top, you see the same, especially again on the lateral side. So my goal is to, talk to you about ACL reconstruction. Why are we where we are today? Where do we do, when do we do repair, and what are our adjuvant procedures? Because as we have seen, there are many other injuries coming along with an ACL tear. I think for ACL reconstruction, everything is pretty much clear. We need to reconstruct and get the stability that we need, not too much, not to constrain the knee. And in our hands here, the suspensory fixation devices, like you see on my screen now, are the best option to fix the grafts. What we see coming up more and more here in our discussions in our hands is bracing, as you see, hopefully big enough on your screen. There is a blue additional suture strand running down the ACL or the graft, and it adds another stability for the more severe cases. And what we do see more and more in the right patient cohort is a repair, and I will go or jump to that in a second. You see that the existing fibers are adapted to the femoral footprint and also mixed with a tape to make it more stable. What we see a lot is that you need a kind of ACL surgery plus, which means it doesn't matter if you have a reconstruction, repair with bracing. You will always have, and this is what the French group said in their video, you can have an ALL injury in a concomitant way, which you can fix with an ALL procedure or Lemaire procedure, but also root repair or ramp lesion on the medial backside of the meniscus might support your surgeries. ACL reconstruction, we did a lot of study here in our departments, and also with support of Artrex. We are using a lot of Artrex devices in our daily business. The first evolutionary step was to understand the stitching techniques. How do you prepare your graft? Is it tripled, quadrupled graft? Where do you put the stitches on? How you integrate your suspensory fixation ones? And we have seen that the quadrupled grafts are superior with a fixation via adjustable or a loop system, and the difference in preparing the graft is not that big and couldn't show any higher differences. And then the next step was to understand how is it aligned between a fixed and adjustable loop device. That's some studies that we did 2-3 years ago with some of the biomechanical people at Artrex, but also with some colleagues like Patrick Smith in the US. And I hope the picture is big enough that you can see it well, but there was several configurations tested. How is it to align a graft with a screw on the tibial side or purely with suspensory fixations? And of course the fixation was higher and the placement was better in the screw fixation. In the suspensory fixation setting here. in these cases, we compared these fixed loops, like the original Artrex fixed loop device, and then proceeded with, as you can read on the right side, tightrope, which is the adjustable loop, and the adjustable loops showed better results. Why? Because what can be done with the adjustable loop devices, of course, that's obvious. You can probably see it on the right side on the screen. You can re-tension the graft after final or primary insertion, and that makes a big difference because you take out the slack initially. And if you look on these graphs, which show the absolute force and the dynamic elongation, then you always see the group called IPC, which is intra-operative preconditioning, which means the graft was re-tensioned after some initial movement of the knee, and you see this intraoperative preconditioning not only enables higher forces on the graft, but also reduces the dynamic elongation later on because you have preconditioned and elongated the graft intraoperatively, which is only possible with these adjustable loop devices, of course. So this was a big learning curve for us. We went for it. We wanted higher forces. We wanted to be as safe as possible and have the perfect setting for our ligaments. And if you compare this again to a screw setting, because you can, some surgeons and many hospitals still use a setting like that with a tightrope, with a loop device on the femoral side and a screw on the tibial side, then you see that also with a screw fixation you lose a little bit of your pretension, but if you have a adjustable loop device on the femoral side, you can return to your initial load by retensioning this graft. And then what you see on the left side is you move your displacement curve to the functional zone of the ACL here, and achieve more or less the same stability like with a only suspension fixation device. Internal brace was the next step that we did some years ago into ACL reconstruction. We found out that many grafts are not working very well. We had still a 20 to 30% revision rate, which is, in my eyes, non-acceptable for such a, let's say, simple procedure like ACL. And this had, of course, many reasons, like graft diameter, like graft quality, harvesting. Sometimes it was linked to allograft procedures, which we don't do too much in European or German market, but still we've seen that the graft remodeling and the strength of the grafts is not ideal sometimes in all our hands. So this is why we wanted to meet the natural ACL's behavior in terms of force and distribution, force distribution and displacement. And how did we do it? We compared the increasing force with the displacement and looked into what is the ACL natural behavior, what is over-constrained if the ACL becomes too stiff, or what is too loose if the ACL is not fixed well as a construct. And what we have found out that in a weak graft, let's say not quadrupled graft or a small diameter, you see that in post-op, but even more in early and late rehabilitation, the hysteresis, the dimension of displacement when putting force on exceeds far to right to the more loose situation of the ACL. So what we did, we added, with support, of course, again by Artrex, some suture material, like you see on this little video. This is what we call internal brace, and you bring back the curve of these ACLs, of these reconstructions, more and more back into the ACL's behavior zone in terms of displacement. And you can, of course, reduce elongation by the same time and increase the strength. And this is the construct. Then it loads your graft on an adjustable loop, and in parallel goes the blue fiber tape, which is fixed separately to make this a stable construct. And yeah, we went on and on with these testings. How many strands do you need? How is the ideal setting of a triple or quadrupled graft? But we have seen a lot of exactly what you've seen before, returning back to the functional zone and getting more stability without over-constraining. This was very important to us, not to have any over-constraint and non-physiologic behavior of the graft finally. And this is what we achieved. We could show that even small graft diameters with internal brace, which is the blue, increase the stability. Repair was the next step. Why not use existing fibers if there is a very proximal rupture? Why not use these strands, refix them, and also, like you've seen before, reinforce with an internal brace construct with no graft mobility, with very anatomic physiologic outcome. And so this was another testing done lately in different settings, I would say, with an anchor fixation, with a adjustable loop fixation, with a fixed loop fixation, and so on, to find out what is the perfect setting for readaptation of the stump to the femoral side. And of course, we have seen that the load that you can attach to this graft, to this, not graft, sorry, but to this reattached stump is higher with an bracing. So the overall gap formation happens slower with a much higher load if the adaptation is done in a very optimal way with the option of retensioning, like with grafting before. And then we added also bracing. So you see the blue strands here. So not only fixation of the stump, which is the first important step, but then we installing a stable mechanical situation via using an extra suture to create this internal bracing. And so finally, with a very certain testing method, we have found out that what you see here, the ACL repair, shows a very big elongation because the stability is not given, but when you combine it with internal brace, with an additional suture, then you find your repair being exactly in the ACL's functional zone and the physiologic range, which was a fantastic result to show biomechanically and also see it in clinical daily practice as well. So I jump over this because this is finally the same data, ACL repair with internal brace, higher forces in this case on our x-axis and lower gap or small gap formation on the y-axis with internal brace compared to only repair. So how do we do it? This is just some little animation or videos out of the OR. So this is a torn ligament, a very big drawer, symptomatics, but still the sleeve, synovial sleeve was existing here, as you see. So we opened up the synovial sleeve, we drilled the tibial footprint with an outside-in drill guide, in a very standard way. This drill guide now comes out through the synovial sleeve, very close to the femur. We transfer passing sutures. Next step is that we put some cinches, some sutures into the stump of the ACL. These sutures will later on hold the stump in place on the femoral footprint. Here you see them attached and now tightened around the proximal footprint, not footprint, but the stump part. They are fixed there to create a very solid hole of the stump of the ACL. Sorry for that, next slide. And what you do now, very simply with an inside-out drilling, you find a right position for fixation. We will get out to the lateral side of the femoral condyle in a very standardized way. Next step is transfer with an eyelet K-wire sutures, passing sutures from medial portal to lateral. And the next step is, you see we have a transfer suture now installed, and this suture now will pull up the stump holding sutures, use sensors, and in the same way it will transport up the button that we need here. So this is what you see in this video. Now the assistant is pulling up, and you see the transfer sutures for the button going transfemoral. You see the button here just outside our portal, and now very important, the surgeon takes over and is now pulling in with his own hands the button to the transfemoral drilling the lateral cortex, as you see here, and up with the button goes the bracing suture, the extra strand that will cause the additional stability. Next step is to tighten this suture, because this is the first step. You will tighten the additional internal brace first, then you do your preconditioning, you do 10-20 movements of the knee to get out the slags in all these constructs, and then the final step is to also fix the bracing on the femoral side, but also tighten the sutures that are holding the ACL stump in place, as you see here. And in extension, it is a very solid, very stable. I play this video again because this is essential. You see that in flexion, you would see that there is still a slag, which is important because we fixed the flexion. But when you go into full extension, you see a very stable construct with the stump adapted and this additional suture in place. Well, just a few words on additional and adjuvant therapies. What we see a lot here, this is another study published from our friends from France, Sonnery Coté group in Lyon. And if you compare isolated ACL repairs and combined with ALL, then you of course see the rupture rate for the ACL is much higher in isolated repairs, and this is something that we try to keep in our minds every day here. So what we do, again, adjuvant therapies like an ALL procedure with any kind of hamstring or leftover of your ACL grafting, or the Lemaire procedure with a strip of the iliotibial band, for example, is something that works well in our hands. And also, what you can see here, we try always to take care and look if there is any root tear on the backside in the knee, or on the medial side, most often a lesion that we have to address with a posteromedial portal and place some sutures on that side there. Yeah, that was my first presentation on ACL, and this is what we see on our courses here, discussed a lot. ACL, when to reconstruct, when to repair, how does it work, and what are the adjuvant procedures for that. So that's it for this talk. If you like, I can switch over to the next one.
Sure.
If that's okay for you, if you still hear me.
Yeah, we are still hearing you. We're good. Thank you very much. You can carry on to the next.
Thank you.
Page, yeah.
Then I just a second. I just have to find my other presentation. There's a that one here. Can you see my screen?
Yes, we can.
Wait a second.
Yep.
Advancements in cartilage regeneration, yeah?
Okay, great. Fantastic. So yeah, this is something new, at least in here it started to be, sorry, on our list in the last 1 or 2 years, and this is a fantastic method that I think in parallel with ACT procedures or AMIC procedures provides a nice option of cartilage regeneration, mainly in the knee. That's why I'm showing some knee cases here. What I have to say is, sorry, it is nothing really new. If you see some early presentations about or publications about minced cartilage, then you see it's from the 80s, and then another list like here shows even transplantations of cartilage in the 60s and the 70s. So this idea for sure is not new. Probably today we just adapted this to the new methods that we have. So what do we do? We again use a couple of Arthroscopy products. In my case, you use a shaver to harvest your cartilage out of the joint of the knee. there is a little filter called GraphNet, which then collects your chips after harvesting, and then with some additional tools like the ACP or PRP system by Artrex and the thrombinator to create a patient's own autologous thrombin, you can run the whole procedure quite easily and time effectively. How do we do it? I will show you in a second. This is just a small animation. This is done not by me, but by Artrex. So what you see they do, they harvest cartilage out of this zone, collect it in this GraphNet, take ACP or PRP from the patient, and mix it all together with some thrombin out of this little container down here, and put it back in the same surgical arthroscopic procedure back into the defect. What is the principle, how we see it? What we need to do is we need to harvest these minced chips, and we have found out that harvesting it with the right shaver is the best way to do it, right? So we can really get small, under 1 millimeter minced chips, and this is the ideal vitality for the cartilage. If you get too big parts of it with knife, that you know that your particle size will be too high, and this gives a non-ideal result at the end. So we need to standardize this to make it easy for many approaches. And what we have seen also in some early testing, that the cellularity, so the amount of cells in our harvested chips is higher if we go into the central part of the lesion, and the more to peripheral we go into the knee, the less cell number is what we get, and also the cell viability is not better outside. So this gave us, let's say, the license to stay with our harvesting in and around the defect area and take out the best cartilage material that you can get. It's location specific, because wherever you get your chips out, they precisely behave like the chondrocytes in that area need to behave. So this is evident data on that. We need to add something, right? We need to add PRP. So we need to support the coagulation. We need to bring in growth factors. We need to attract stem cells, be anti-infective. This is why PRP is mixed into this procedure, and this is exactly what happens here with ACP and PRP, and the chondrocytes with their environment around this chondron, how it's called, the outside cellular matrix, and you can cover the defects in the best way. And PRP is providing like the power, and the fibrin, as you see on this little video on the right side, is creating a clot that will finally seal your procedure. How does the workflow work? So again, beforehand we cutted the chips by hand, but they were quite big. So what we do now, we started to use a standardized shaver, and this creates and provides a much nicer surrounding of this defect, but also gives a very precise and very defined size of the cartilage chips. This is a kind of 3.8, 3.6 millimeter shaver that we use and collect these chips in this GraphNet device. And this is the result after harvesting, and this is more than enough to fill the defect. If you have an open procedure, you can of course harvest cartilage chips with a sharp spoon or something, and then you put them in a little sterile bowl, put some saline in there, and then you just suck them in with your shaver that you have used in the beginning anyhow, and you will finally create the same result as you see there on the right side. If you have bigger flakes, then this makes sense to again use the sharp spoons, even if it's an arthroscopic procedure, and then harvest the flakes like that. If you have a smaller defect or smaller particles, then the shaver is good enough to start with in the beginning. Always important is to very well clean your surrounding, because later on you will otherwise interfere with some soft tissue, with fat pad. So it's a big tip to clean up your joint well to have the best access to your defect zone later on. And as you see here, we are sometimes even creating a more lateral superior portal to really perpendicular get to our defect. One portal more sometimes saves you a lot of hassle when implanting back your cartilage chips. Next step is to take out the water. After you harvested your chips, you can dry out the knee, you suck out the water, and even with some clips or washers, you create a very dry environment like this. Now we have mixed the chips with some ACP. You see it here, and it gets like a toothpaste device. And then again, after drying out the knee, sorry, it's not proceeding. There we go. Sorry for that. My video is not running anymore. Can you hear me?
Yes, we can hear you.
Okay, just my video doesn't run, so I will start over again probably. Sorry for that. My PowerPoint stopped, so just a second. I think I'm back. So you have seen the cartilage chips being mixed with the ACP, and then still not running. I don't know why. Go back. Sorry for that. I have to restart probably my PowerPoint.
Not a problem. It's okay. We can wait.
Yeah, let's see what happens. Okay, so we have seen the paste being mixed, and now you see with a certain device, which is just a nice blunt cannula, you press out this minced cartilage mixed with the PRP inside the defect, and it's not necessary to fill the whole defect. It is even better to just fill the base of the defect and maybe to fill halfway of the defect height, because otherwise you create an overstuffing as the material in the cartilage is growing later on. You see the defect filled now, and with a thin needle there goes a portion of thrombin on top of it, which will seal the defect. And you have seen, I can play this video again. Where is it? Sorry, now I play this video again because you see how the drops of thrombin are getting out and adhere automatically because they're very sticky to the defect, right? And then you can probe the whole situation, but you don't have to. Sometimes we just make a final movement of the knee in full flexion, extension, and we see a very good, very sticky and very stable result of our cartilage chips mixed with the PRP and sealed with the thrombin on top of it. If there is a leftover of the PRP, then we just inject it into the knee, because why waste patient's material? The growth factors will do what they have to do, and anti-inflammatory and anti-infective, and so we never waste material. We always try to get it back into the patient. And this is how it looks like at the end. Some tricks: always choose the right patient. We had a weight-bearing guy like this coming in with a defect, not too big, but this is probably not the right patient. It needs to be more non-professional sports person, or at least not somebody who lifts like 500 kilos. But other than this, we are very flexible with our choice of defect sizes. As we know, expectations into such surgeries are not that high. We don't need to bring them all back to their professional sports life, but being back in normal activities, of course, is what we are aiming for. And we have seen that from a defect size perspective, you can cover nearly every defect. It doesn't matter how big it is, from 2, 3 to up to 10 square centimeters easily. So smaller defects, big open defects, everything works well. And even in some cases, you can treat patients with other options like osteotomies in place as well, of course. Traumatic cases are the easier ones to treat, because then you have fresher grafting and fresher surrounding. In very degenerative cases, we try to very well distinguish and draw the indication more carefully. But we know that, again, the vitality of cells is better in acute cases. You can do and combine it with many things. You can combine it with some meniscus tears, of course, and you can combine it with ligament stabilization, osteotomies, open cases. Important is that you add a single-step procedure with this minced cartilage autocut procedure. You need a good bony bed, so if it's very sclerotic bone, sometimes you have to take away something. If you have more like an osteochondral lesion, then you have probably to also fill it with some autologous bone from the iliac crest, for example, or some synthetic bone material, which probably is the second best option, and works well anyhow. What you see here is if you prepare the bone bed very well in osteochondral defects and then prepare a solid base for implantation, you still get a very nice coverage. In this case, it was a very deep osteochondral defect. We filled it with bone material and cartilage chips on top of it. The result was quite impressive in this case. It is possible to do it arthroscopically, but also non-arthroscopically. So on patellas or bipolar lesions, sometimes non-arthroscopic procedure is the better choice. On patella cases like this young lady with a very isolated chondral lesion, it was done in an arthroscopic procedure. You see the pictures out of the arthroscope here, and in some cases like this one, where you don't reach well the defect zone, it is easier and you do less harm finally to the patient if you go for a semi-open or open procedure. And these, of course, are bigger ones, big lesion covered with some synovia on top of it, or two lesions in the same patella. These are all, of course, suitable cases for an open procedure. Important is to really use any kind of fibrin and thrombin, and again, emphasize to use an autologous method like a thrombin. You put the PRP into this container, you have to wait 10 minutes, and the thrombin clot is forming itself, so it's a fantastic tool for that. And again, when you suck out the water, you see how well everything aligns at the end. This is important tip to really take care to make your joint dry later on. HOFA, sometimes you see some HOFA particles in here, because when harvesting, sometimes we tend to also take away some of the fat bed, and we know that there are precursor stem cells and vascular stoma vascular fraction of the fat. So this is another add of biologic ingredients into this surgery, which we make a lot and see good results with. Rehabilitation, another tip, quite easy. We were very careful in the beginning. Now you see there is a partial bed rest, but the patients start moving quite fast, 6 weeks, and partial weight bearing, and then another 4-6 weeks. It depends on the symptoms in a partial weight bearing procedure. Then you see in this case 5 weeks post-op, another second look because of another injury, and we see that these chips are still in place, nothing moved even after the other accident, the fall. And you see in this MRI after 3 months that the cartilage is still there intact and the healing process and the consolidation goes on. So we have the good feeling that this becomes a stable construct very soon. Return to sport, that's very individual, it depends on the sport. If it's non-contact sport, we would say 4 to 6 months is a good range of time for it, but we have to keep that in mind and follow our observations and adjust our return to sport policies here by time. Indications can be everything from kids to oldies. In a very healthy state, you can also treat like 60, 70 years olds. As I said, defect size can be very different because you always get enough material from the surrounding to put back in. It can be osteochondral. Sometimes you need to think about some bone material to fill in the defect then. It can be bipolar, which is not that easy. I would not recommend to start with bipolar chondral lesions, but you can move to it. And of course, you have always to take into consideration core pathologies. If your leg axis is not perfect or the patella alignment is not perfect, then of course your autocart minced cartilage procedure will not be successful at the end of the day. So you have to think about the root cause of the damages and of the degeneration. So finally, what I want to leave with you as a take-home message is that we like this one-step procedure. As we have seen it a lot now in our hands. It's quite quick. It demands no transplantation of chondrocytes and bringing it to a laboratory and any population of it. In most cases, we do arthroscopy now, and this is what the market sees in general with these minced cartilage procedures. When you boost it with PRP, when you take your local specific chondrocytes, you see that the differentiation, the result is really fantastic. And again, sealing it with thrombin, placing it in a nice, not too high position in terms of the level of the cartilage, and then bringing in ACP again provides a nice and fantastic result at the end of the day. So this was my second highlight that I wanted to show to you: ACL reconstructions, cartilage reconstruction, cartilage repair, and I think this is what you can see this on our daily thoughts and development in our hands here in Munich, in Bavaria, and Germany. Thank you very much.
All right, thank you very much. This was an excellent talk. 2 talks.
Thank you.
I'd like to ask the audience for any questions if they have any. If you have some time for us, that is.
Yeah, sure. I'm still here, so we can discuss for a couple of minutes for sure.
Thank you. So, any questions? Perhaps I'll start off. What are the long-term outcomes of the procedure that you've shown us?
You mean the cartilage, minced cartilage procedure?
Yeah.
Which is something that there are some publications out by Italian groups and a French group. In this new setting with AutoCAD in terms of only autologous components, only autologous thrombin, autologous PRP, we are getting now to 2-year results, and the outcome is quite good in the early results. We see a stable fixation. We didn't have any bigger revision rates. We have 1 or 2 cases that we revised due to infections mainly, so all those things that happen anyhow without having really control on it. We had a revision to do the fall, as you have seen, so any kind of accidents and any kind of patient non-compliance that happens also. But based or linked to the technique, we don't see any dropout so far. We see really quite fantastic results and quite happy patients.
Okay, we have a question.
Thank you very much.
This is an extension of the first question. So, in the past, the other cartilage regenerative procedures like ACI and MESI were considered to be the gold standard, especially for the larger lesions. And you've said that with this one you can actually do up to 10 centimeters across. So I'm wondering, I don't know if there are any outcome studies that compare the outcomes of the previous methods, ACI and MESI and this one, because I'm thinking this is probably better. It's a one step surgery. It's a single stage surgery rather, and I suspect it might be cheaper in the long run, and this is really important for us in this part of the world. Thank you.
Yeah, thank you for your comment. We see the same here. It adds some easiness of use for the surgeons to do that kind of procedure. You don't have to plan, you don't have to do like two-stage surgery, right? And yes, we have to compare it to the gold standard because we need to know it from a clinical evidence, but also because other side, we also have to prove it, also have reimbursement, at least by the European healthcare systems, otherwise we not really are able to do it on a larger scale. And we have two or three universities here in one here in Europe, another one is outside in Germany, and the third study is running as a multi-centric study in UK, in Switzerland, one Dubai-based, one hospital, and they are looking into the outcome results in a more thorough way. Yes.
Have you sometimes considered using microfracture together with cartilage procedure?
Some surgeons that we know already do it, already saw it, but I know some surgeons try to do it, but I think it's not a good idea to get an overreaction of the bone structures with some osteophytes and some spikes, and as we know, sometimes from pure microfracturing, and we know that we provide enough agents from a biologic standpoint with our cells, with our growth factors, with the chondrocytes, by the procedure itself, so we don't need to add this kind of support by the bone potential. So we would not recommend any microfracture.
Okay, thank you very much. Thank you again. Looking like there is no other questions from the floor. So thank you very much for your talk, Dr. Chasek. And we'll let you carry on with your activities.
Thank you very much. Thank you for having me. Next time I will join you in person. I would love to be there. But for today, I'm sending the results from Munich, and have a good rest of your meeting over there. Thank you very much.
Well, thank you again.
Bye bye. Bye bye.
Right. So now we have two talks for the morning session. Am I heard here? So we have two talks remaining for the morning session. That's Dr. Miano and Dr. Lutomia's talks. Dr. Miano, we are to talk on failed ACL reconstruction, reason and repair techniques. want to see if you can finish this one. Yeah.
Yes, good afternoon, everyone. Thank you for the opportunity to give this talk. I think it's quite an important talk for the young surgeons. As you're starting your profession in arthroscopy, you will probably get to see one or two cases of someone who had an ACL done that failed. So, I mean, you want to look knowledgeable. You want to look knowledgeable to your patient, and for them to feel like you know what you're doing. Yeah. For the older surgeons, it's important because it will help us to just have a feel of how we would investigate, or if we had done an ACL earlier on in our practice and it failed, why did it fail? So yeah, so basically we are just going through that, and why an ACL will fail, and then what are the repair techniques that we have, or what are the repair options that we have. So this, in a nutshell, summarizes what I'm going to talk about today. What are the causes of failure? And I'll summarize them into three. Technical errors, which is the surgical technique. This will account to up to 80% of why your ACL will fail. Yeah? And 80% of our failures will be because of tunneling of and tunnel position. So as we go through and we start doing our ACLs, just pick a femur model and go through that position that Professor was talking about earlier this morning. Try and locate it, because it's quite important. Yeah, biology, and that includes did you get an infection as you put in your graft? Was the graft incorporated well, and or did we get a rejection of in people who do allografts? And then a small percentage they will get a re-injury. So you had your ACL done, then someone went back to their sporting activities, and then yeah, they got a secondary injury that led to failure. So it's estimated about we have about 200,000 ACLs done in the US. I don't know, locally I think we should start a register, because the number of people doing arthroscopies is getting higher and higher, to just compare and see. Our people are also getting involved more in sporting activities. During COVID, and people are working from home, yeah, we saw a big percentage of people going to the gym and getting associated sports injuries. Yeah. So, and as we get more and more people getting these injuries, definitely the revision rates will go higher and higher. So why does an ACL fail? Yeah, so it could be a multiple of reasons, multifactorial. But one is your tunnel placement. As I said, tunnel placement. Most important thing to remember out of this talk is tunnel placement. I can't emphasize it even more. Choice of graft and the biology. What kind of a patient that do you have? Is it a high active patient who is into active sports? Were there any associated ligamentous injuries that were missed during the initial diagnosis of your ACL? Was there an osseous malalignment? Was there a bony malalignment with this ACL? And then more and more is the meniscus. We were told earlier on about meniscectomies. I think people are trying to move away from that because of the importance of the meniscus. We can't stress it more. So yeah, tunnel placement. If you put your tunnels too vertically, you tend to have rotational instability. On your femur, if you put it too anterior or too posterior, you get either graft laxity or loss of range of motion. Yeah, so we try and get the position right from the word go. Try and get the position right. Look at and try and restore the anatomical footprint as much as possible. This will make you avoid issues of rotational instability. Okay. Ligament. Did you have an associated ligament injury? Again, physical examination is really important. You need to do your stress X-rays. In a patient who had a primary ACL done that has failed, you need to do stress radiographs. You need to check for their MCL. You need to check for their LCL, the posteromedial and posterolateral corner. Are they stable? Yeah. Your anterolateral ligament, is it stable? Because then all that, if you're gonna revise, it will still fail if this hasn't been addressed. Limb alignment, yeah. You want to check, do full long leg films, yes. You want to check for your mechanical axis to be sure that you don't have, or your patient doesn't have a varus knee. Because again, as I said, if you have malalignment, if you're gonna repair, if you're gonna get, if you're gonna revise, it will fail if this hasn't been addressed. Yeah. So patients who have insufficiency, ACL deficiency with the malalignment, you need to address the malalignment. So that's where we have a role of high tibial osteotomy plus revision of your ACL. If you're gonna revise someone who has a varus knee with an ACL deficiency, you need to address that. The posterior tibial slope. People talk about it a lot. I just want to summarize it so that it makes a bit of more sense. A line through your tibia, okay? And then a perpendicular line 90 degrees to it, which is line 2 there on the screen. And then the line that line 3 is on the condyles, yeah? So normal should be, the normal posterior tibial slope is 7 to 10 degrees, which should be maintained. Again, as you're investigating a patient who had an ACL done that failed, you've checked your ligaments, you've checked your mechanical axis, check for your posterior tibial slope, because this might be the cause of why the ACL is failing. Okay, and this posterior tibial slope is both bony and soft tissue. In terms of the soft tissue, the meniscus play a role, yeah, both medial and lateral. Yeah, so try and preserve as much meniscus as you can, because then that will cause instability. Yeah, so normal is 7 to 10 degrees. Anything more than that, there's a risk of failure. But this should only be done when you have checked all the other causes that might have contributed to your failure. Don't go osteotomizing your tibia because of the slope while you haven't checked the other causes that might have caused your ACL to fail. Yeah, I think that's basically what I've said. Yeah, meniscus and meniscus preservation more important, and if you're gonna have an ACL that has failed, check did the meniscus, was it preserved? Yeah, you know, meniscus act as secondary stabilizers in an ACL, in a knee with an ACL. They act as primary stabilizers in an ACL deficient knee. So you want to maintain your meniscus. It is an important stabilizer. It is an important stabilizer. Yeah, so if you have a tear on your medial meniscus, say secondary stabilizers in an ACL deficient knee, and you want to try and restore that, because then there's an increased risk of failure with a knee that with an absent meniscus. Yeah, so preserve as much as possible. Yeah, you want to maintain the hoop stress and the stability on your knee with an intact meniscus. So you have had revision. Your patient presented with a failed ACL. A lot of controversies as to whether you want to do your revision in a 1-stage or 2-stage. Maybe Professor will give us a comment about that and his experience. Yeah. You want single stage or 1-stage? Yeah. If your prior anatomical, if your prior tunnels, if the previous tunnels are not on your way, if the first tunnel, the first ACL that was done and the tunnels are not on your way, you can do it as a 1-stage. If the tunnel diameter of the previous ACL that was done is less than 14 millimeters, you consider it doing a single stage ACL. Anything more than that, probably you need to do it in 2 stages, because you want to fill up the spaces that the bony loss that is there for your graft to be integrated. Okay, so in 2 stages you want to fill up the bony spaces, make them rest for about 4 to 6 months, review with radiology and radiologic examination to see if you've achieved bone integration. Yeah. So in a nutshell, what are the factors that influence your success after you're doing a revision surgery? You need to check all of this. You need to check your cartilage. You need to check your meniscus. You need to decide on the type of graft that you will use. Surgical technique. It's a steep learning curve, but I think over time it's doable. Your rehabilitation. Again, maybe Professor will give us a comment on that. revision ACLs and rehabilitation? Do you start them off immediately? Do they work immediately? And then patient's compliance and enthusiasm, because I mean, what are the patient's expectations after your revision? Remember, revision surgeries are more difficult than the primary one. Chances of failure of revision is much higher. Thank you.
Thank you, Dr. Miano, for that good talk. Next, we have Dr. Lutomia to talk about multi-ligament knee injury.
Thank you. I'll not keep you long because I know you are tired. Inshukisha sana. Yenye nikutumia kwa email ile ilikuwa multi-ligament. The reason, I think, let me start by saying that we should individually or independently examine how each of the ligaments around the knee is repaired and not rely on this kind of talk to tell us exactly what to do. Each of the ligaments are special in a way in how we repair them, the ACL, PCL, collateral ligaments, the corners. Each one of them, we need to know how each is repaired, and then we can be able to conceptualize what I'm talking about. The important thing about multiple ligament injuries is the recognition of the severity of injury. It is important to realize if you get a knee with multiple ligament injury, the first thing should run in your mind is a possible vascular injury, and you know that if there's a vascular injury, the limb is in danger. But not only that, it's usually a high energy injury, and so it's good to know that the patient could have other life-threatening injuries that include and are not limited only to the limb, chest, and all the other trauma-related issues. Now, we say that a knee has multiple ligament injury if there are more than 2 injured. Once you get to 3, then you need to realize that that was the classification earlier on today about how we classify those dislocations, the shank, and there are various combinations of that. I think the next slide talks about that classification, the shank classification, which we have already gone through. During evaluation, we have to assess the limb at risk. And hoping you have assessed the patient by the trauma methods, the patient doesn't have life-threatening injuries. Now we have limb-threatening injury. And the finding of, I think the take-home message is that don't just be in these people who say dorsalis pedis palpated and it was okay and you haven't done it. And then the other thing is that a finding of a good pulse at the casualty or day 1 does not prevent or does not mean that limb will be necessarily alive 48 hours later. So repeat evaluation of this limb is very important. Number 3 is that sometimes you can have good clinical impression, but when you do the ankle break your index, you find there is a problem below 0.9, then you need to send this patient for evaluation, because sometimes that's CT angio or MRI, because sometimes there is you can miss endothelial damages. And then in terms of approach to manage, so of course if there is vascular injury you need to seek help from the vascular guys, and most of us should be well trained to be able to handle a vascular injury anyway. But in case you are not able to do that, you should be able to seek your colleagues
to help you repair the vessels quickly before the limb goes. So we profile the patient in terms of, in the past, multi-ligament knee injuries were managed by casts, and also the limbs turned out stiff. But they were good for people who are, manual workers and stuff. Stiffness is fine. But now with a lot of people going into sports and the need for motion, so now it is no longer, the trend. I don't consider things as controversies. I consider them as trends. And I think the trend now is more towards surgery rather than non-operative management. And now that we know and we have a lot of things at our disposal to repair each and every ligament, so more and more people are getting confident and the functional results are getting better. I think the urgent need when you have faced with these injuries is to reduce, and there are many methods of reducing it. And then you splint, and if you can use a brace. If the patient is heavy or you are getting instability, you put an external fixator, as Dr. Deng has talked before. Then you take investigations that look at the limb vascularity and x-rays that help you to determine what injuries you have. I think in the acute setting, it's very difficult to do a clinical examination that is useful. So because the limb is swollen, the patient is in pain, so you rest it. Once you have confirmed that there is no vascular problem, there is no compartment syndrome issues, then you rest the limb in that brace or whatever external fixator until the time when the knee is talking to you that you can now do some surgeries. So the aim is to realign, stabilize, then manage the vascular injuries and fractures. Problem comes in when you have fractures together with ligament injuries. That is a challenge, because then we usually manage the fractures first, and maybe the injuries that we wanted to repair, like collateral ligaments and maybe a meniscus, then later on maybe you might even have to remove the implants before you do the internal reconstructions of ACL and PCL. Now, when you look at these ligaments, certain ligaments are able to repair themselves. So I'll say very general statements. For example, the ACL is in a hostile environment. It is a round ligament. The vascularity is poor. The cellular population inside is not so good. So generally it gets intersubstance tears. So the ACL is usually a bad ligament. Most of the time you'll require to repair it. The PCL, on the other hand, is an extra-articular, so to speak, ligament with good vascularity. It has meniscofemoral, those Reisberg and so those extra tissue that usually provides a scaffold. And so the PCL, and it's a broad ligament, which means even its contact surface can be better than, say, the ACL. And also because of this, when you look at the cellular population, it has a higher cellular population. So the profile of the PCL enables it to actually have a chance of healing. As opposed, and most of the time the ACL injuries are avulsion, fractures or something in the posterior, which can be fixed and then it will heal. So when you look at the type of injuries between these ligaments, there are different profiles of these ligaments. Pick the lateral side and the medial side. When you look at the medial side from an anatomy point of view, it's just a broad sheet, the MCL, and with a lot of cells. And that broad sheet means that if it's injured, there is a chance that fibrous union will give you another broad sheet, maybe some laxity, but you can get healing. That's why the MCL is likely to heal with very few, it's likely to heal compared to the outer side, where you have tubular ligaments that are crisscrossing obliquely. Others are going this direction. The oblique ligaments are going like this. So when they heal, you get this fibrous network of tissue that doesn't help you. So the lateral side we tend to repair. The medial side we can manage without surgery. In some cases, generally speaking, medial side femoral avulsions you can manage without surgery. Tibial avulsions you may need to do surgery. Lateral side we generally need to do surgeries. Now, in terms of the timing, early versus late, again, these are not really controversies. I think that if you rest a knee within 3 weeks, the soft tissues and what that are likely to heal, the capsule will close. Even if you needed to do an early arthroscopy, the capsule has now closed, and now you can do gravity. Maybe gravity is you run the fluid by gravity, and you can be able to do something in the knee. But if things are just torn, you still have fractures, you can't scope that kind of knee. So it is wise to wait maybe 3 to 4 weeks for the early goers. LaPrade still considers up to 6 weeks as early approach to the knee in terms of repair. So the people or some of us like me who do that early approaches, we believe some of these things like avulsion fractures, avulsions of these ligaments, you can be able to repair them and augment the repair by fiber tape for those that you can be able to repair. If you wait, then you have loose fibrous tissue and you have to do elaborate reconstructions, which can be very expensive. But in general, if you're going to repair, let's say, the collaterals, then you might leave the ACL and PCL for later reconstruction. It is okay to repair both ACL, PCL at the same go when the knee cooled down. That is after you manage the collaterals. Problem is if you leave a knee wobbling around and maybe the meniscus was intact. Later on when you come, you have so many injuries. Apart from the collaterals, you have menisci that are torn and even maybe worn out. So now you have so many injuries to deal with and your outcomes are not as good. But remember, early surgeries, more stiffness, late surgeries, better movement, but more injuries to deal with. I've talked about this and the thing about the approach for the PCL has already been elaborated, and ACL, the pitfalls, but you can stage this later, maybe when you already finished the collaterals and stuff. The only thing to say, during examination, you need to recheck. Everybody needs to recheck that you can have a lateral collateral ligament injury, but when you examine, even under anesthesia, you find that you are getting laxity on the medial side. A false laxity on the medial side, you have a medial collateral ligament injury, you expect laxity on the medial side. During examination, you get laxity on the lateral side. You need to know how to examine the knee such that when you are checking that valgus varus stress, the bones must be congruently arranged. You must reduce the joint before you test the collateral ligaments, otherwise you might open the wrong side. Because sometimes the condyle has slipped off, and then it gives you a pseudo-laxity on the wrong side. So that's why sometimes you find that people you might end up opening the wrong side. So I think most of the things that are in these slides, you know. If the patient prevents late, for some reason they were in what guys in Nairobi call the periphery, they were casted, and then they come to you late. At that point, you need to evaluate what are the functional needs of the patient. It's not always necessary to repair some of these, especially like the PCL. It may not be necessary. Sometimes even the ACL has united the cyclops in a manner that is giving the patient stability. The age of the patient is 50-something, 60-something. The knee is already degenerate. So you must ask yourself questions before you go scoping, because you know how to do an ACL. But the patient already has arthritis. What are you doing? So you assess the functional needs of the patient at that time, determine if there is disability, and consider operations to achieve a very realistic goal. A quick point to mention is if you're going to do maybe collateral ligament or even ACL in a knee that has malalignment, maybe has varus, as valgus angulation, it's better to do the osteotomies to correct those, because those can contribute to your failure. And that is likely in the patient who has come in late. Patient has come late, maybe there's some degenerative changes, or there's a fracture that was not managed adequately, there's malalignment, then you need to correct that malalignment. Rehabilitation depends what you've done. Of course, initially when you repair the collaterals, you brace and avoid the full range of motion, so that you put them in the position where they are likely to heal, especially if you did repairs. If you did repair plus augmentation, then the mobilization might be a bit quicker because the fiber tapes keep you, but you must realize these things are expensive. These guys will, you might find that by the time you're using those fiber tapes and swivel lock is 60,000, another swivel lock 60,000, fiber tape is 30,000. You know, they are not cheap things. NHIF has given you 200,000. The implant guy has gone away with all the money. Now what about you? So it's important to realize these things Prof was talking about, use of PDS and stuff to repair things, because cost is real. So protect if you think your repair needs protection, early mobilization to avoid stiffness, and I think the hamstrings, when the patients fire hamstrings, they put a lot of stress on PCL. So if you let your patients sleep, say prone, and then you tell them you think they are open chaining exercises and flexing their knees, you're putting a lot of strain on the PCL. So it's good to avoid those kind of things. So you do the simple things as Dr. Winger talked about, foot presses and stuff. But early range of motion if you don't have meniscal or collateral ligaments that are inhibiting your rehab. I think that these are unit dependent. Every guy has his own way how he does it, and then return to sports. You must tell the patient will be after a year. Thank you very much.
Thank you very much, Dr. Lutomia. We can have the morning presenters, please, for a quick panel discussion. I have some intelligence report that our lunch was delivered at a wrong venue. It is being rerouted, so we have some little time for questioning and answers here. Karibuni. Maybe to start, Prof, there used to be what they used to call accelerated rehab after, especially for high-profile athletes. They want to go back to sports very, very early. Maybe do you still have that, or it was outdated totally?
I had a personal experience of karate fighter, who became European champion after 3 months ACL surgery. So that's how it came. I didn't tell her, do this. I said, don't do it. I said, skip the championship, go ahead, and then I will allow you, depending on your situation, 6 to 9 months. So why did this happen? How did it happen? I don't believe it will. So it's her ability. So how did this happen? First of all, I used a tendon bone graft. So that's one thing. The other, she's European champion. She's elite. She knows how to move. She knows how to act. And it wasn't her dominant, the one that pivots. It was not the dominant leg that she takes the energy from, and there was nothing else, no collateral damage, no cartilage, no meniscus tear. So she started walking day after, good pain management. So I believe in accelerated rehabilitation, definitely. But when you walk or when you do a lot of things, the ACL doesn't bear weight. The ACL bears weight in pivoting. I mean, a marathon runner, 42 kilometers, the ACL will have limited force on it. So in this period, the patients, the idea of accelerated rehabilitation is not to load on the ACL, but other structures. That's why it's important to have closed kinetic chains. Like if they can start leg press day after. Because concentric contraction on both sides. The hamstrings and the quadriceps run together. And nothing happens on the ACL, but there shouldn't be additional damages.
Thank you. Thank you. Any more questions? Any more questions?
Question master. Question master. Question master.
So I have comments for both Miano and Lutomia. So I'll start with the ACL. So for ACL, I have a comment and a question. So I've been seeing quite a bit of revisions in my hospital at Smoi. And I realize that most of the surgeons actually are placing the tunnels correctly. So I don't think that right now tunnel position is a big issue as it was like 10-15 years ago. A lot of surgeons are now very keen where they place the femoral tunnels. But what I'm noticing a lot is that a lot of surgeons are using hamstrings for the wrong patients. So you get a young patient who's playing rugby or playing soccer, and you're using a quadrupled hamstring, and to be honest, the best you can get out of a quadrupled is maybe 8. If you're very lucky, 9. So, and I like what Prof mentioned yesterday about the stiff grafts. So we should all learn to use the stiff. Let's learn how to do the quadriceps graft, and you can do it with a bone plug, you can do it without. Let's learn how to do a BTB. A lot of people are shying away from BTB, so let's all learn these techniques. And also there's one that I'm also trying to do, the peroneus longus. There's not too much data on it, especially outcomes and stuff, but for the patients that have used, they seem to be happy. They don't have eversion weakness, they have normal gait. So, and I think that's one of the grafts, and I think it's stiffer than a hamstring graft. So that's one. Now, the question for Miano. So for revision ACLs, in our part of the world we don't have allografts, and some of these patients have very huge tunnels, even up to 15 millimeters across. So, and you mentioned about bone matrix, bone fillers. I don't know if you know of any companies that can supply us, that can start supplying us with this, because I'm seeing it as we start doing more revisions, we are going to have that as one of the hindrances. So that's Miano. So Lutomi, and then I finish all my questions. No more questions today. So now for the multi-leagues, I usually stress to my residents about the importance of acutely reducing the knee and keeping it reduced. So, and you need to do, I usually tell my residents to use a CM. When you go to theater, reduce the knee, use a CM, perfect lateral, make sure that knee is centered. And make sure you keep it as such. Because see, the problem is if you don't do that, what happens with gravity, the tibia starts to slide posteriorly. And if it stays that way for 2 weeks, you start getting contractures. And these patients come to me in the clinic a month later down the line. If the knee is stiff, it's not moving, I really don't know how to help them. You can't reconstruct a stiff knee that is posteriorly subluxed. Thanks.
Thank you.
Yeah, thank you for the question. I think locally we don't have. I don't know of a company that is supplying bone plugs, but the options that are there, maybe we can use an iliac crest graft to fill up the bony spaces that are left. That's what I've come across. I don't know.
Almost all these guys who provide implants for spine have some kind of bone substitutes that you can use. If you get hold of any spine rep, they'll get you those either blocks of bone or powders. So that can help. Then you can add your PRP and blood fibrin clots and stuff. But maybe you can try that. I agree with you. The use of peroneus longus is little published in literature, but a lot of it, especially in India, they use it, and I had experience with an Indian surgeon who taught me it's a very simple harvest, and you get a bigger tendon. So that's something that is worth considering, especially in revisions or when you want a bigger tendon and the bone to bone grafts. A knee that is dislocated, if you leave it free on pillows, tends to go into recavetum. Not even only. In fact, one of the ways to pick that this was probably a knee dislocation, when you just look at the patient, you see the recavetum. As that sign, the recavetum is a sign that this knee has multi-ligament injury, most likely it was a dislocation. And aside from the stiffness, it's even more likely to put tension still on the artery. So you are very right in saying that we need to hold it. That's why we have a low threshold for external fixator. And sometimes you'll hear guys say that's an overkill. It's not. If you find any sign that this knee is subluxing back, then you put an external fixator without regrets, because it's a temporary measure. And usually after a few weeks when you move now, you can even brace it by that time.
So the first comment on your comment. Hamstring being a reason for revision. Don't forget, if it's the cause of the graft, it's a gradual failure. You don't see it in the first in the first month. It's gradually it stretches out. So if it's early failure, you have to look for other reasons. For the late failure, so a question was addressed to me: the single stage or double stage. It depends on the tunnel where it's located. So sometimes it's a region of the graft, and the tunnel is perfectly located. I confirm it with C-arm to make sure it's in the correct place. So I use the same tunnel. And if it's widened less than 14 millimeters, I use a bone graft, quadriceps tendon or patellar tendon. I try to keep as ipsilateral as possible. Then contralateral, I very rarely use allograft. We can find allograft, although expensive in Turkey. And or it is completely away from the original tunnel place. Then that's easy also. You just open up a nice 9-10 millimeter tunnel in the femur, and the other is away from it, and you make it like a primary. And if there is nothing else, meniscus or cartilage, then it's like a primary surgery. Then it's called revision, but primary surgery, so it's accelerated rehabilitation for that patient. But the biggest problem is when they overlap, like MasterCard. And them. It overlaps. Partially. Then what I do is, I measure the previous tunnel and I insert a bioabsorbable screw. Do you like it?
It fills the tunnel up.
It fills the tunnel up. And then I open up my new tunnel. And usually it eats up like 1/4 of the bioabsorbable screw. And then it's also accelerated rehabilitation in this patient. And you also asked about the expectation of the patients. It's a drama. We talked earlier about infection after ACL. It's a drama. Of course, it's not death, crippled, whatever. But for these patients, athletic activity patients, it's a big drama. So we take that seriously and discuss it with the patient, talk with the patient, and respect the depression that they will go in, because it's true to be away from the field for so long. Just be prepared for the resentment that comes with it.
May I ask, Doc, how many of us use manipulation and anesthesia? You know, we grew up during this time. When somebody is stiff, you are taken to theater until sometimes fellows come with fracture femurs. I just want to, how many of you actually, you have done a scope, and then you take a patient for manipulation and anesthesia? Okay, so what is the aim? Because, Prof, you have a comment on this? I'm a Dr. Kali. Maybe you, because you did, you can comment.
So, but, go ahead, please.
No, usually you try to improve on the mobility, and most of the time it doesn't work. Yes. So you treat yourself more most of the time.
So I think that's the message I personally would have liked to communicate, because when you scope these knees that are stiff and you look at what you see inside is a forest of fibrous tissue. So if you're going to take it and then you break all of them and each one of them is bleeding, and then the following day the patient is in worse pain, they even hate you. It's better if you just go and do arthrofibrectomy, but I don't know, but maybe you're about to say something.
So this is a patient with arthrofibrosis, loss of flexion and extension. Yes. What is the reason?
Most probably slow the rehabilitation.
No, biologically, what is the reason?
A lot of biology inside.
It can be a lot of contractures because of the bleeding. And late starting of the range of motion. That's one reason. But the most important one, is it because of the wrong placement of the graft?
Maybe not.
Maybe so. Because they are the ones that are most difficult to. You have to rupture the ACL for that to happen. So this is one thing you have to make sure. It is not because of the graft. Because this is very frequent in these cases. That's one thing. And the second thing is, there's loss of motion in extension and in flexion. Flexion-wise, manipulation under anesthesia almost always works. You get the flexion. You get the flexion up to at least under 20 degrees. But extension just under manipulation, it will not come. The patient will still have loss of extension. And other thing about manipulation, there will be bleeding, so proper pain medication, immediate CPM. You have to restore these and then do the manipulation. How I do it? I don't do it closed. I always do it arthroscopically, and I don't use shaver. I don't use shaver, only the arthrocare. And I recreate the suprapatellar push, which is about 10 centimeters proximal to the taba, superior part of the patella. And then lateral push, medial push. So I have a hour system, the 12 o'clock, 2 o'clock, go down, go back, and detach the PCL and the ACL. And then in the front, I clean up all the fat, and I see the patellar tendon. I clean up the in front of the meniscus and the patellar tendon. That part is the one that's causing the loss of extension. So the front part causes the loss of extension, and I recommend you, if you have a case like this, cut out a piece of the tissue that was once a fat pad, but now a fibrotic tissue. It's like this. It's just like plastic. The tissue changes character, and the patient changes character as well. It becomes aggressive, and so I definitely believe in. I've had several cases interfering, but avoid bleeding. I don't want to clean everything out. I just cut with the arthrocare, cut the connections.
Thank you, Prof, for that comment. I think the take home, this manual thing doesn't work. I have had several patients like that. What I have done, maybe it was wrong, was I go in and you even when the scope in, you are in a forest, you cannot see much. So in fact, your initial shaving is just to create an area now from where you can work, because you get in and you can't see anything. So you use your anatomy to see that, okay, I'm unlikely to be shaving the quadriceps anyway, and then you keep an eye, and then you finally see, and then I shave, and then I use the ablator later on to coagulate the bleeders. And so what I do is I shave, I flex, I see how much am I getting, extension. Then I shave, how much am I getting. When I'm satisfied, I stop. But I use a shaver, and then in the end you have used like 2 or 3 blades to finish this exercise. But it has never worked by the manual just flexion extension.
So how many minutes do you spare for such a surgery?
Like 3 hours, honestly.
Yeah, good. But do you prepare from the beginning? You end up 3 hours, but in the planning.
Now I know.
That's the usual situation. You know, people think it's simple surgery. I just manipulate, shave in and out. No, it's 3-hour surgery, just like ACL. Delicate, fine tuning here and there. Gently see how it goes. It's not a simple surgery. It is simple what we do, but it takes time.
Thank you very much, Professor Mutiso.
Thank you very much, Ronald. I really like the answers that I'm hearing there, especially the last 2 comments. We've been at this for some time, where there's some of the older surgeons, and we were more general than specific, so we were a little bit wider. But what we try to pass to the residents is that the anatomy and the biology is really important. If you don't respect what those things try to teach you, then you'll do the wrong things. I mean, if the only exception for that kind of manipulation, of course, is in something like the shoulder, where there's adhesive capsulitis, but that is a different kettle of fish. So it's always good to understand what the biology is, what it is that is happening, and when you interfere, what it is that is likely to happen. Even when you're examining a patient, I mean, you may not necessarily need to know the name of that examination you're doing, but you know, for example, what the supraspinatus is doing. So when you are testing a movement, you are thinking of that muscle and what it is that it is doing. You know, it's not then it stops being rocket science. It just becomes common sense. I'll make a few more comments, and you just bear with me. A little bit of what has happened over time. We heard about complications. There's a time we dropped a graft, an ACL graft, on the floor in theater, and you could have had a pin drop. The person who was preparing the graft behind me was passing it to me, and the assistant turned and knocked it, and it dropped on the floor. And it wasn't nice. So we put it back and prayed, and the patient actually did very well. I did something perhaps I should not have done. I washed it with the betadine and then rinsed it with saline, and it went very well. Another comment was on peroneus longus. I think peroneus grafts. I think the country is reaching a stage where there are a lot of arthroscopists. We are really on the threshold of taking off. There are many more arthroscopists coming up, and there are younger ones who are taking interest. I think you should publish this stuff, because unless we publish it, that takeoff will be delayed, a little bit delayed. Size of interference screw, if and when you use it. I once put, and that's not too long ago, we lacked something to hold, and the agent, the rep, suggested we put a size larger than what we had done. Admittedly, I've done that before, and it has worked well, but in this case, it broke. So I just wanted to find out from you, what are your experiences of putting one size larger? Finally, to the whole panel, but maybe mostly to Dr. Lutomia, multi-ligament repair. I know I've said that you should be a bit intuitive in what you do, but I recently had one. In fact, you probably know the patient, because the patient was from Nakuru. I can imagine you know who it is. And we had planned to do it at one go, which I think was not a good idea in the first place. And we ended up doing it in 2 stages. So by the time I was doing the PCL, we had already done the ACL. And you can imagine trying to reach the back. Now, something else probably I should have done was to put a portal at the back, but I didn't, and we still repaired it. So I just wanted to find out from you. Okay, I'm admitting that maybe the planning wasn't good enough, but in terms of using of posterior portals and stuff like that, how often do you do it? And seeing that I really managed to put this PCL at this time, is it something that you would try if you had thought it through in the first place? Thank you.
Thank you for that question, Dr. I will not hesitate to use a posterior-medial, particularly portal. Because first of all, we don't even have I don't have 70-degree scopes, and for me it makes work so easy when you are doing all the when you are working from that portal, posterior portal, than having to navigate all through here and get your things at the back. But you must be tough for you to manage without. For me, when I went to these courses and learned that you can do those portals posteriorly, and they make your work very easy, it has changed the way I look at arthroscopy. You don't have to struggle. If you put your needle, you can see better from there. You put the scope there, you see things better. So the working, the shaving, everything, you get down very well with a 30 degree if you put those posterior portals. So I would encourage you to use it more frequently than not. I don't know, Prof, do you use? Or Mian?
Yeah, I think it makes your life easier if you if you get to the back. I mean, a posteromedial portal helps and changes everything. It gives you a different scope. It gives you better view of the posterior condyles and where your pin would come through. And I think that's the way to go.
I will add one more to it. Open the posterolateral portal as well. Then it's like watching a theater from balcony. Because you need three hands, one for the scope and one for instrument working, and so definitely posterior portal.
Thank you very much. I think we give a clap to the panel. Dr. Rocco, you can ask your question during lunch. Yeah, it will be easier. Thank you very much, everybody. The van has just arrived, so you can proceed for lunch.
Each one of them refer to something else. So which one, what it refers to, we have to understand and get more information about the patient. So the age, if it's a 60, 70-year age patient, it's another story. If it's a 20-year-old patient, it's another story. But basically, two sets of patients that we consider for surgery. There will be more pain or more instability. And surgery is usually not good for the pain. Surgery is usually good for the instability. Pain indirectly to offload the involved compartment. So if there's more pain, there are arthritic symptoms, chronic ligament deficiency, and there will be mostly pain. And then some giving way, and HTO will be used here for offloading the compartment. When there is more instability, you have to add ligament reconstruction as well, because it is the ligament construction that caused this situation. And you have to preoperatively plan the patient. If there's effusion, there must be cartilage or meniscal problem. So you have to know that. There's always this discussion about whether to do arthroscopy with osteotomy. I always do arthroscopy with osteotomy because of these issues. There must be, not to regenerate the cartilage, that's not my aim, but to clean out any mechanical blockage. And we have to understand the range of motion. Bilateral standard weight bearing is important, and the tibial slope is very important. MRI will show us the soft tissue status. So this is a case. Patient has arthritic symptoms. I hope you can see the X-ray there. Chronic ligament deficiency and coronal sagittal deformity. So I would do a biplanar medial opening wedge osteotomy. And then while doing the osteotomy, if you can adjust the posterior slope. If you put your wedge implant posteriorly, it will decrease the slope. But if you put your implant anteriorly, it will increase the slope. So it's important where you put it. And closing wedge is good. It allows you to bear weight immediately. And in difficult patients, obese patients, you may choose this. But in active patients, because you can play with the tibial slope, and you don't lose the limb length, I prefer the open wedge. and in another patient with chronic ligament deficiency, and there is the malalignment and pre-OA changes. So, and in this patient, I would prefer ACL reconstruction as well. Now I do it in single shot. I do the HTO. What I do is I prepare the inside, the femur first, drill the hole, take the grafts, and prepare it, and then I do the osteotomy. After doing the osteotomy, I prepare the tibial tunnel, and then while the tibial implant is there, I make sure that the passage of the tibial tunnel does not interfere with the screws. So I put a metal 9mm drill into it while I place the screws. So if the screw interferes, then I change the position, and then I carry it on. I find the single stage to be successful. And then I use post screw. I don't use interference screw for the distal tibial fixation of the graft. Open wedge, again, the tibial slope. That's something you can assess in the lateral X-ray. So these are some literature information. I think you can look it up in the literature, but my personal preferences in the young patient, I do it together. Alone, they can bear it. If the patient has, sometimes I'm not sure, and instability, but instability is not so due to pain or mechanical issues, and change the tibial slope, and that would be a patient that I do double stage. First osteotomy, and then do an ACL reconstruction. This is a good example. If you can adjust, if you open it more on the back side, tibial slope will be diminished. So if you do the tibial slope, the hyperextension should not lead to hyperextension greater than 5 degrees, 0 degrees of extension in cases of PCL surgery. So in summary, indications are ACL deficiency plus varus with a thrust, and then there's the other type of patient, posterolateral thrust. There's the ACL deficiency and increased tibial slope. This is a failed ACL because of the tibial slope. It needs to be revised. And posterolateral instability with virus plus or negative hyperextension thrust, and chronic PCL instability. So these are the types of all of the malalignments that will respond to osteotomy. And these are the operative techniques that we can use that I briefly went over. And it's important to designate the amount of correction. So we designate the point located at 62.5% of the width of the tibia plateau. Draw a line to the center of the femoral head from this point. Draw a line to the center of the ankle from this point. The angle formed by the intersection of these lines is the correction angle. And that would be 4 centimeters. You enter the osteotomy 4 centimeters below the medial joint line, and you head for the fibular tip. And then this segment, carry this line segment as continuation of the distal line drawn to the ankle. Measure the distance between the proximal part of this line segment and the line to the femoral head. that distance is the wedge distance. So I can send you the slide to everybody. It took me a lot of time to prepare these arrows, but this tells very quickly, very nicely of what you should do. So thank you for listening. I escape. I close this. Okay. Lateral extraarticular procedures with ACL reconstruction. So we always think of the anterior translation issue as a single ACL problem, but peripheral structures are important. The idea of ACL reconstruction is restore knee stability. We have to remember the peripheral structures, prevent secondary injuries, and prevent the development of OA. All are good results, but up to 11 to 12%, 30% of the patients, there's residual rotatory instability. So there's a problem. And in order to address this, double bundle techniques were proposed, and but still it didn't result in good solutions, and it's almost abandoned. Now anatomic single bundle is preferred, but more attention is given to the peripheral structures. Those at the age of about 50 will remember with segment fracture we would think, and we didn't really know what it was for. But we knew that if there was a segment fracture, that meant that the patient had a higher rate of ACL rupture. So with a single X-ray, we would think this patient has ACL. But now it's very clear to me that fracture is avulsion fracture of the ACL, of the ALL. So anterolateral ligament, fiction or fact, it's always discussed. My personal opinion, whether it's a ligament or a part of a capsule, it has a function in the rotation, controlling rotation of the knee. And don't forget, some people walk with their knees externally rotated, internally rotated, and they have different demands on the peripheral structures of the knee. So I find these, is it a part of capsule or a true ligament, academic gossip, I should say, but trying to reach evidence of it. I believe in the function of it. That part, ALL, controls the rotation. And again, some knees require a lot of rotation control, some do not, because everybody is not flexible as the others. So there are 3 layers, and I will go quickly. These are available in the internet. This is a KSSTA, anterolateral complex of the knee, a pictorial essay. Volker Musal, also a good friend of mine, in Freddy Fu's team, he did this, and it shows the lateral structures. Lateral structures are distant to us. Medial is more injured, but you should be aware of it. There's in the layer 1, the iliotibial band, biceps femoris, and as you go in, the deep iliotibial band comes, and the Kaplan's fibers from the iliotibial band into the distal femur has a role in controlling the rotation. And then as you go further down, you come to the capsule, and within the capsule you will see the anterolateral ligament as here. It originates from the front of the lateral collateral ligaments femoral attachment onto the proximal tibia, and this is how I would show this to you, and insert at the second fracture site. So this is an expert group consensus paper. It's a distinct ligament, deep to the iliotibial band, femoral attachment, posterior and proximal to the lateral epicondyle. Tibial attachment is between Gerdes tubercle and fibular head. There's constant attachment to the lateral meniscus. So lateral extra-articular tenodesis is something different than ALL reconstruction, but it goes over the ALL ligament, and I would consider them to be replacing each other. So it's a proven method. It increases stability in combined ACL and lateral capsular deficiencies. So this is the technique I prefer, modified Lemaitre technique, and this is the left knee of a patient. So what I did in this patient is lateral exposure, open the fascia lata, and take a strip of 10 centimeters with 1 centimeter width, and then expose the lateral collateral ligament, pass it under it, and then fix it superior to the lateral femoral condyle. Once the ligament passes under the lateral collateral ligament, it's isometric. So you can fix it at any point, which is about 30-40 degrees, and that's how it is. I used to do it with a staple. It was strict, but I had complications in patients, staple loosening, and which caused a lot of problems for these athletes. And now I use absorbable interference screw in these techniques. And there have been other techniques trying to simulate this. So lateral reconstruction, capsular reconstruction has been used all along. And this is the one that I would use in complicated cases, and especially in children, pediatrics sometime. Just pass it over the top, under the LCL, and back into the proximal tibia. So this is an extreme example of a patient. I hope you can see the images now. She came to me with a history of 5 months earlier. She had anatomic ACL reconstruction and started to have pivoting episodes at 4 months. And she had aggressive rehabilitation. She's very high level athlete. She was at the Olympics last year. I did this 4 years ago. She returned back to national team. They become 4th in the world in the Olympics. So this was the case. I don't know how clearly you can see, but the endo button is in the notch. Where it should be at the lateral cortex, but it's in the notch at 5 months postoperatively. And this is the 3D image. See how posterior it has been, and it even fractured the posterior cortex. Plus, she had lateral medial meniscus tear. So what do? Single stage, double stage. I did it in single stage. So just like giving a lecture, this wasn't a live surgery broadcast. It was me, my fellow, and the nurses. So you see under the video, I put a A4 paper. I put everything down. Diagnostic arthroscopy, femoral tunnel assessment, tibial tunnel assessment, meniscus evaluation, meniscus repair, and then femoral tunnel preparation. I informed the patient, and then because it's a revision case, I plan to do an extra articular tenodesis, and I used allograft. So I put the Achilles tendon allograft. Very few patients, of the very few patients, I used allograft. I pulled from the tibia in the joint over the femur back onto the tibia. So this is how I prepared it. It's open and arthroscopic together with a wide incision. So this long, I hope you can see, it was too long, about 35 centimeters long. So the graft is coming inside from the tibia, going to the posterior, inside the joint, coming out from the lateral condyle, like extra articular tenodesis. So it became like the Macintosh, Stefan Zapagnani Macintosh technique. Like this. This is where I got the inspiration. Because this is already a proven technique. To use the same graft inside, over the top, come back out. I don't usually do this, but because the tunnel was so badly prepared, I had to choose this. Other than do a double stage, fix the femoral tunnel, etc., too much wouldn't happen. And I put the stable fixation on the lateral side and fixation on the Gerdi tubercle. So, and this patient, again, like I said, she's back in the field, all these dramatic things that are being done, and she became fourth in the Olympics in Japan. So thank you for listening.
What was the length of this?
It was like 35 centimeters, too long. I had to cut the end. Achilles allograft.
Questions?
Question monster. No more.
Yes, I did.
So finally, I could deliver a good speech, which didn't leave room for question.
Anybody?
Can we ask you something about the morning talk? Perhaps you already asked. Is it working? Okay, this is about the morning talk. Maybe this has been asked when we were away, but I'll just ask it because I really wanted an answer. So there's these patients who have chronic patellar instability. They have a little bit of a valgus, but they don't come for attention until they develop pretty severe osteoarthritis of the knee.
How old?
60, 65-year-olds. And even when you are examining the patients, there is definite subluxation of the patella. And then you ask yourself that when I do this knee and do the replacement, will that patella track well? And are there any tips that you can give us on that?
I'm a soft tissue surgeon. I'm not an arthroplasty surgeon. I can give you my answer, but I'm not an author in this topic. So I'm not expert in this topic. But what I would do, first I would, in these cases that are close to me, but not my real expertise, I always consult somebody who's the real international expertise. I send him the pictures, I talk to him before surgery, and I ask him simply, you think I can do this? He says, yes, you can do it. And I say, what should I do? says something and I do it. But they're my very good friends, and sometimes they say, don't mess with it. Some things happen with the fractures, with the forearm fractures, etc. They say, don't mess with it. And then I send them the patient. And so I never had a complication with this way. But I have consultants, very close to me, friends. So in this case, most of the problems of arthroplasty come from patella. So really I would try to see if there's a lot of valgus, then you correct it in surgery and the problem is solved. But I don't think that I wouldn't go for any tuberostas tibia. That's beyond my knowledge. I wouldn't do that. That's too risky in an arthroplasty patient to put more implants.
Thanks, Prof. You were talking about the HTOs and all that. There's some people who are doing the PFOs, proximal fibular osteotomies, just to offload especially for a varus knee, and then they do a diagnostic at the same time, and then they check the meniscus on the medial side. If it's having a bit of problems, they shave it, and then they just do a PFO and they leave it. No HTOs, no nothing. I don't know if you've come across that.
I didn't do any. I'm actually waiting for further results. There's conflicting results. At some point about a year ago, it impressed me. If we can find something like that in 60, 70-year-old patients. But I'm not convinced yet, so I wouldn't put it into my practice until there's evidence. What do you think?
I was in a center where they were actually doing quite a lot of those, but definitely patient selection was one of their things. They were not going for the elder patients, so they would do it for the younger ones and give them more time. And though it was not documented, but the few patients I saw, there was a bit of, positive results.
Would you do it on your patient? Are you convinced enough?
Well, if it's going to postpone someone from, let's say, a replacement and all that, then yeah, I would initially try.
That's the question. Will it postpone?
What is the science behind doing a fibular osteotomy?
So basically, they want the fibula acts as a strut whenever, like when you're doing that. So when they do the PFO, they literally get rid of that strut concept.
Column.
Yeah, the column. Yeah, the column. Yes. So what happens is that then with time, as the patient is bearing weight, there's that alignment change that happens. That's the only concept. Yeah, now that's, you see, that's why the way Prof is saying, it needs more and more investigation as to what's happening.
Yeah.
You mentioned alignment. Is it radiologically documented alignment, or is it just... No. My question is very simple. When you have done this, the principle is that you're going to alter the alignment, isn't it? Okay, because if it's alignment, then there are radiological measures of alignment which you'd like to see.
And maybe they just denervate the joint. Maybe they just denervate the joint. Like we have such procedures around the shoulder where you just break the glenoid, then you let it heal and the pain seems to have gone away. Maybe they just denervate the joint. Another question?
Yeah, thank you, Professor, for the talk. For the patient that you had, who you did tunneled through the tibia, the femur, and back into the tibia, the original CT scans look like the main concern was tunnel placement. Yeah, why not just address that and see if the patient improved instead of taking it back and or what made you choose to reconstruct the ALL?
This is what I wanted to answer before you asked. The tunnel is wrongly located, definitely. I would not put it there. So my choices were either find a solution like this or plug the back part which broke the posterior wall. How can I do that? I have to get a 9 millimeter, 10 millimeter long plug of 4 centimeters that will stick there, or I have to do approach posteriorly, adventure to do something like that and wait and then do it. I just relied on the previous people experiences, this Marcacci and Zaffanini, they still do these kinds of, but they add the ALL, so they work together, the ACL and the ALL. So I trusted in some of their information, and I did it. It worked, but it was like 10, 11 millimeters wide. The Achilles graft was very strong, both in the ACL and the ALL. And she's very good. She's very good, really. One of my best patients, but a hard worker.
Another question? Prof, is there a criteria for choosing this patient I can repair ALL, this one no?
Well, it comes, first of all, don't you have a feeling that a patient comes and you say, if I do just ACL in this patient, it will fail. So this patient would be grossly pivoting. Of course, you have to look at the ramp lesion in order to have that, or recurvatum, not to the pathologic degree, but recurvatum. And then you think about should I use hamstring, stiffness issues, like you come to detail in patients. So this football player comes and you say, okay, ACL, no additional problem, it goes. So in these patients that make you think, I always put an ALL. Because after all these years, there's something that makes me suspicious, such as the hyperlaxity, grossly pivot shift, and lateral, a little bit of varus, but not to the extent primary varus, not to the extent of osteotomy. And it's a simple procedure, Lemaitre, not ALL. I'd like to call it lateral extra-articular tenodesis, Lemaitre, not ALL. It's a very simple procedure. Learn it, and then it's an additional 15 minutes.
The question in the morning, can you ask now? Okay.
No, it was a comment which we went and discussed. The issue is that over the years you see certain practices, and this particular one I was talking about multiple ligament injury, dislocation. I had a colleague who, as a resident, was a pilot. He jumped from his plane and had a dislocation, and he had all these ligaments torn, and he was treated in a cast, and he never required anything further done. He finished his orthopedic training and became a consultant, and he used to do all these ACL reconstructions, but his was not. So that made me think about just conservative treatment, putting a cast. And over the years, I'll put casts and discuss with the patient that after some time, some of the ligaments will heal, and those that have not healed, then we can repair them. And I haven't written anything, but
I've been able to repair 1 or 2 ACLs, but it's quite surprising how conservative treatment can work. Not that I'm recommending it, but if you are in an area where maybe the circumstances are that you can't do it, an elderly patient who has had this, it's not an option which does not work. It actually works, only that now we have got better equipment and we are able to do that. Just a comment, because it is something that I've actually done, and a number of patients have come back and said, no, I don't want anything done, and they are fairly comfortable. Not in young patients, but in maybe older patients. So it does work, conservative treatment. That's what I could say. Yeah.
Experience is important.
Thank you for that comment. Any other comment? I think that wraps up the afternoon. Sorry?
Rocco, there's a classification for dislocations. Eh? Did you classify those dislocations you're talking about? Because there's 1, 2, 3, 4, and then there's accompanying injuries to each of them. Was there any classification you did, or you just diagnosed and then you put in the cast?
So I haven't classified them, but these are patients who had dislocations of the knee, which meant that they have at least had 3 ligaments. And because, as you mentioned, PCL tends to heal. The medial collateral, a lot of time tends to heal. And then you are left with the ACL. So I'm not recommending this as what should be done. All I'm saying is that it actually works. That if you are in a situation where you don't have all the equipment or the, you are not able to do this, you are not committing a crime by actually dealing with that, and then later on you can deal with what has not healed, maybe the ACL. To answer the straightforward question, no, I didn't classify them.
I think if we pass a message that surgery is compulsory, we must say, I must correct that what Dr. is talking about is right. If you, even in literature, it's true that you can manage them conservatively. But what is happening now is that people now are classifying these injuries, and then now you look at the outcomes. Then it looks like those that end up with surgery have slightly superior, better scores for the knee. Not that it is wrong or something to manage them conservatively. I think that should not be the message. Thank you. That wraps up the afternoon talks and also the workshop. So now that we have a theater, two patients. Okay, so we will talk to the theater team to set it up and we get going. But thank you very much, Prof.
Thank you
for gracing this workshop, and you're welcome to sit in and enjoy the rest of the sessions.